Hello and welcome. I want to welcome you to this 2022 AES meeting. It is a great pleasure to see all of you here back in person. It's also a delight to have really an in-person meeting again where we can talk to each other, see each other, and enjoy each other. And we have a very exciting program throughout the entire AES. I want to acknowledge Ignacio, who is our chair of the annual meeting committee and has to make sure everything runs well. Before we start, there are some housekeeping items. First of all, the faculty here presents cutting-edge information and unpublished data. So we do not, not allow photos to be taken of the presentations. All presentations will be available on demand for 3 months after the meeting. All faculty participating in educational activities like this one has to disclose their conflicts to their presentations, and also if you want to know more about the disclosures, you can find them on the AES website. If you need credit, CME credit, the online evaluation and credit claim will be open until March 31st, 2023. You must complete the evaluations and claim credit by that day. Pharmacy credits must be claimed by January 13th, 2023, so a little earlier. And we are back to an app, so please make sure you download it. Please look at the AES website of all the accredited programs and further details how to claim the credit. I also want to put your attention to the poster sessions. The poster walking tours will be in the poster hall this Saturday, Sunday, and Monday at 12 p.m. at the author's present time. And please make sure you come and talk with all the young and enthusiastic people about their latest research. With that, we're going to start the symposium. The specialist symposium is about what is a seizure after all? And there I want to tell a brief story. When I graduated medical school, I was pretty sure that I knew what a seizure is. And now I have done epilepsy for 30 years, and I know less and less what a seizure is. And I hope that the symposium will enlighten us in the end. Basically more, is there a seizure or is it something else? So with that, I'm going to give it over to Ignacio, who's going to have some words for you.
Thank you, Barb. We have no disclosures relevant to the content of the symposium today. These are our learning objectives. I will give a moment to read them. We have a busy schedule today with great lectures going from basic to clinical science. And we will introduce the lectures and the speakers as we go along. I will start with a brief introduction. The word seizure is derived from the Greek and means to take hold. With the oldest scriptures going back to 1 to 2000 BC, on this Babylonian tablet, there are descriptions for the falling disease and to cease. The etiology was presumed to be the effect of demons and ghosts. Around 400 BC, Hippocrates, a Greek physician, argued that epilepsy originates in the brain, and when an excess of phlegm enters the blood. The word epilepsy comes from epi, upon, and lepsis, seizure. Here are the 4 basic Hippocratic humors: blood, phlegm, yellow bile, and black bile. Health was defined as the harmony of these humors, and epilepsy was thought to be due to an excess of phlegm. Aristotle suggested that an excess of black bile produced seizures, and Galen believed that the soul was based in the brain and epileptic attacks occurred as a result of involvement of the brain. The Persian physician Avicenna, in his book Canon of Medicine, stated that the clinical manifestation of a seizure may be associated with its origin, like in the brain, the stomach, or the spleen. In the 19th century, John Huglins Jackson, an English neurologist and father of modern epileptology, stated that a convulsion is but a symptom and implies only that there is an occasional, an excessive and disorderly discharge of nerve tissue on muscles. And the British neurologist Sir William Gowers, who referred to John Huglins Jackson as his mentor, published the book Epilepsy and Other Convulsive Diseases, where he gave a detailed account of the disease and its treatment, including bromides. This was before the EEG era. In the 1970s, the World Health Organization and a group of world experts led by Henri Gastaud published the Dictionary of Epilepsy, where the seizure was described or defined as a sudden and transitory abnormal phenomenon of motor, sensory, autonomic, or psychic nature due to an excessive discharge of hyperexcitable population of neurons. And then the International League Against Epilepsy in 2005 and 2010 defined an epileptic seizure as a transient occurrence of signs and symptoms due to an abnormal, excessive, or synchronous neuronal activity in the brain. So what can we learn from different viewpoints? And for this, I'm going to let Dr. Jobs introduce our first speaker. Thank you.
So I don't think the first speaker needs a lot of introduction. This is Sean Gottman, who I respect as kind of the father of all electroneurophysiology. And he is at the Montreal Neurologic Institute. He actually was for a while at Dartmouth, but studied at Paris and got an engineering degree there. You probably know a lot about his work in detection of spike and seizures. And he has written over 340 peer-reviewed papers. And he will enlighten you what he thinks is the long and tortuous route from interictal activity to seizures.
Thank you very much, Barbara and Ignacio, for asking me to be part of the symposium. I will start first by disappointing you because I'm not going to tell you what a seizure is. I'll really talk to you about interictal activity, which is kind of an introduction into the whole field, and maybe a little bit how interictal activity relates to seizure in some way. So I have no disclosure, and these are the learning objectives. Become familiar with the temporal and spatial relationships between interictal activity and seizures in focal epilepsy. I will concentrate on focal epilepsy, and become aware of some of the factors that affect these relationships. So let's start with a few definitions. We're going to talk about 3 types of events. The seizures themselves, which I will not go into trying to define what are subtle seizures. We talk about real big seizures, the one we just heard about. Interictal spikes and sharp waves, clearly separated from seizures. And then interictal high-frequency oscillations, which I assume you're familiar with. These distinct high-frequency events that have been seen mostly in intracerebral EEG, but also in scalp EEG. So we're not considering these borderline events in this case. So the question I want to ask really is, are interictal events and seizures generated by the same mechanisms, with interictal events considered in a way as some micro-seizures which can, under special circumstances, become clinical seizures. In this view, similar factors would affect interictal activity and seizures in the similar ways. For instance, interictal activity would increase, as seizures do when you reduce anti-seizure medication. And increasing interictal activity would be a harbinger of seizures. Lots of spikes would mean a seizure is likely to occur. I would like to take another view, however, and even though we do have interictal activity almost always in the situation when we have seizures, in humans and in experimental animals, we will see that we could consider interictal and ictal events as distinct pathophysiological phenomena that are in many ways independent of each other. They can, of course, provide information about each other, but they are really independent phenomena, and we should not always think of interictal events as something that is related to seizures just because seizures is what we're interested in. The brain generates all these events, and we can try to see how they relate to each other. But seizures are not central to them, if you like. Let's first look at the temporal relationships. We will later look at the spatial relationship between interictal spikes, HFOs, and seizures. Spikes and HFO rates change over time. They're presumably affected by different factors. We will look particularly at sleep, proximity to seizures, anti-seizure medication levels. Seizure occurrence, of course, are also affected by a multiplicity of factors. So the specific questions we will ask are, does sleep affect spikes, HFOs, and seizures in the same way? Do anti-seizure medication levels affect spikes, HFOs, and seizures in the same way? And are spike rates and HFO rates predictive of seizure occurrence? So the first question, does sleep affect spikes, HFOs, and seizures in the same way? We see here in this meta-analysis by Ng and Pavlova of over 500 patients and 2,000 seizures that seizures occur predominantly during sleep. You have, let me see here. I don't see the, oh, whoops. We had an interference between different things here. Okay. So we see here N2, N3, N1, which take, in terms of seizure occurrence, a much larger proportion than take the time that they occupy in real time. We've seen particularly that REM sleep, which takes something like 8% of real time, has very few seizures. So non-REM sleep, this is a strange, non-REM sleep facilitates seizures, and REM sleep inhibits seizures. So now what about spikes and HFOs across the sleep and wake cycle? Spikes are clearly activated by non-REM sleep in most patients. Values in REM sleep and wake are usually similar. This is from the same paper here. We see the maximum spiking rate is, so I'll try again. The maximum spiking rate is in stage N3. You see here in almost 70% of patients. And it is in REM in over 10% of patients. This is where we have the maximum spiking rate. As an aside, this may result from the facilitation of spikes by individual slow waves, which of course are very prominent during N3, which we demonstrated with Birgit Frauscher a few years ago. So individual slow waves facilitate spikes, so spikes are very frequent in N3. But what we see from this and the previous slide is that there is not a particularly good correspondence between the stage of maximum spiking, which is mostly N3, sometimes REM, as we see here, and the occurrence of seizures, which are largely and relatively equally facilitated by N1, N2, and N3. So the two don't really fluctuate in the same way. And as an aside, we can see here that the spike rate, which is highest in N3, is not a particularly good indicator of seizure occurrence, which we will come back to. This is the effect of sleep stages on HFOs in mesial temporal lobe structures. This is relatively similar in other structures. We see here wake and REM are relatively similar. In yellow and blue, you see HFOs that occur together with spikes or outside of spikes, but the graphs are relatively parallel. And we see non-REM sleep here with a high activation for ripple and for fast ripples. So this is very similar to spikes, with slow wave sleep activating HFO occurrence. So to come back to our question, does sleep affect spikes, HFOs, and seizures in the same way? Non-REM sleep activates spikes and HFOs compared to wake and REM, which are similar. Seizures are also more frequent during non-REM. But stage entry is by far the stage with most often as the highest spiking rate, whereas seizures are more frequent, again, in relation to their time of occurrence, to the duration of occurrence in N1 and N2. Seizures are almost totally absent from REM, a difference with spikes and HFOs, which are reduced but clearly present, with some patients even having high spiking rate during REM. So our conclusion for this question is that there definitely are some parallels, but there are also very clear and very well identified differences in the way sleep affects seizures and affect interictal activity. To our second question about anti-seizure medication. This is an old study, which I like. It's mine, of course. And we studied 44 temporal lobe epilepsy patients, 24 with scalp EEG, 19 with intracerebral EEG, during a period of gradual anti-seizure medication reduction. In these days, the medication was reduced in the epilepsy monitoring unit, usually very gradually. The main result, which is not what we expected and not what most people still believe today, indicate that drug levels do not influence spiking rate, and spiking rate does not change before seizures, but increases markedly after seizures, particularly after secondary generalized seizure. So what I want to emphasize here, because as you will see, this has been replicated, drug levels do not influence spiking rate. This is from that study from 1985. We see here drug levels over the days of monitoring, 10 days of monitoring. These are plasma levels that are going down for the drugs that are taken by the patient. And this is spiking rate in the right temporal region and the sphenoidal electrodes here, which is totally unchanging. There are no seizures occurring during that time, you will notice. But the spiking rate is totally unchanging during this period of gradual decrease in medication. This is another example here. This is a patient with intracerebral electrodes. This is medication reduction. The dosage and the plasma levels are the black dots. Spiking activity in the left temporal lobe, in amygdala and hippocampus here, in the right temporal lobe here, and here we see seizure occurrence. So at the beginning of the monitoring session, we have about 2 or 3 weeks of monitoring here. We see that there is probably an implantation effect with variable spiking rate here. Then there is stable spiking, even though medication is decreasing quite rapidly. Then the first seizure occurs here in the right temporal lobe, and spikes increase following that in the right temporal lobe. Notice that they don't change in the left temporal lobe here. Then a burst of seizures occur in both right and left temporal lobe. We have increase in spiking following that here and here. Then the spiking starts to drop again. Another seizure on the left side, and spiking increases again following the seizure occurrence. These results were largely replicated and with small differences in a study from Susan Spencer with 34 patients having grids and depth electrode. I will just read quickly from the results. Spike rate in all recorded contacts consistently and significantly decreased after AED withdrawal. So we had found no change after AED withdrawal, whereas most people think there is an increase. In fact, what they found here that there was a decrease in spiking rate. Despite variability in initial spiking rate, diurnal occurrences, seizure character, number, localization, onset, and types of AEDs continued or withdrawn with very significant result. A significant increase in spike rate was noted in the 24-hour after seizures of medial temporal origin, which is what we had studied. Interestingly, and this occurred in medial temporal lobe contacts, this did not occur in neocortical seizures in their study. What do HFOs do when you change medication? This is, we have to, now that we know that seizures have an effect, we have to be careful that we separate the effect of seizures and the effect of medication, because when you reduce medication, seizures occur. So what we're comparing is before and after seizures at periods of no change in medication. And then we're also looking at when medication is reduced and there is no intervening seizure. So in that study of Zilemann's, we found that we replicated the earlier study, again, that spikes increased when you compare before and after seizures, when there's no medication change. So spikes are increased by the seizure, but if there's only medication reduction, there's no change in spiking. And HFOs, on the other hand, did the reverse. So HFOs were not affected by seizures, but were affected by medication. So to come back to our question, do ASM levels affect spikes, HFOs, and seizures in the same way? Of course, the reduction in anti-seizure medication results in an increase in seizures. By definition, these are anti-seizure medication. But in the absence of seizures, the reduction in anti-seizure medication does not affect spike occurrence, whereas it increases HFO rates. In the absence of medication changes, seizures are followed by an increase in spiking rate, by no change in HFO rate. So, as a conclusion, anti-seizure medication reduction results in seizures, of course, and HFO increases, but does not affect spiking. So, the increase in spiking, which most people believe occurs as a result of medication reduction, is actually not the result of medication reduction itself, but the result of seizure occurrence, which often follows the medication reduction. So you reduce medication, the patient has seizures, then the spikes increase. But if the patient doesn't have seizures, then the spikes do not increase. So this is emphasize again the different ways in which these different events react in the context of medication reduction. Now the last question we ask is, with respect to temporal relationship, is are spike rates and HFO rates predictive of seizure occurrence? And I'll just show one slide here from this study, which I'm not going to get into the detail. I just want to show some examples which are quite striking. These are days of monitoring. This is spiking rate, which, as you can see, increases very much here during sleep in many cases, and sometimes it's constant. And in red there, you see the seizure occurrence. And if you just look quickly at this slide, you will see that sometimes spikes occur with high spiking rate. This is done independently of medication. The medication is not looked at in this case. They just look at spiking rate and seizure occurrence. Sometimes spikes occur with high spiking rates, sometimes with very low spiking rates, sometimes here at the onset of a period of high spiking rate, sometimes at the end here. The conclusion really is that 63% of IED clusters showed no relationship to seizures. 37 showed some relationship, almost equally distributed between pre-ictal and post-ictal decreases and increases. And of course, in general, this is probably because the medication was not considered. But the conclusion we can clearly draw from this is that the spiking rate is not a good predictor of seizure likelihood. It has also been shown, and I don't have time to show this, but in a study that we did with Julia Jacobs, that HFOs do not systematically increase or decrease before seizures. The HFO rate is therefore also not a good predictor of seizure likelihood. So we have in these cases very clear dissociation between interictal activity and seizures. Now let's change topic a little bit and look at the spatial relationship between spikes, HFOs, and seizures. Do seizure spikes and HFOs all originate in the same region, which we commonly call the epileptic focus, the epileptogenic zone? Are some events better markers than others of this epileptogenic zone? In this context, we have a big problem. We have a problem of propagation. Seizures propagate a lot, we know that, it's very clear. Spikes also propagate a lot. Fortunately, HFOs do not propagate very much. And this is a powerful feature that they have. So the questions we will ask in the context of spatial relationship is, can you tell with confidence if a region where a seizure starts was found? Which I will argue you cannot. Can the spike onset zone be found, and how does it relate to the seizure onset zone? And can HFOs indicate where the epileptogenic zone is? So first, can you tell with confidence if a region where a seizure starts can be found? Whether using scalp EEG or intracerebral electrodes, we can only record from a small fraction of the cortex. There's no way out of that. That's a very fundamental physical issue. Doesn't matter how many electrodes we put, we always record from a small fraction of the cortex. So are the characteristics of EEG discharge that are specific to the real onset, so that either we know we have recorded it or we know we've missed it? If there was a pattern in the EEG that told us you're at the onset, then we could say, okay, we have this pattern, therefore we're at the onset, or we don't have it, and therefore we missed the onset. And of course, we've heard many times that the low voltage fast activity is a characteristic of the onset and that its absence indicates that the onset was missed. But I really don't think this is correct. I show you here an example from a study of Piero Perucca that we did a few years ago, where we look at different patterns at seizure onset. But the specific point I want to make here is that the pattern of spread can be the same as that of onset. Here we have a subset of the intracerebral electrodes in this patient, here in the left superior cingulate region, where we find the earliest seizure pattern. It's a low voltage fast activity, which you can argue is the seizure onset. 1 or 2 seconds later, we see the same activity in the contralateral right superior cingulate region. So what can we say from this? Of course, if we did not have this electrode here, we would say this is the onset. Now we say this is the onset. But of course, the onset could be somewhere else. And this could just be spread, just like this is spread. This is another example here. Electrodes in the orbitofrontal region, anterior cingulate, amygdala, low voltage fast activity here, low voltage fast activity here, low voltage fast activity here. Do I know that I found the onset? And the last example here, which is maybe even more striking here, this is a patient with implantation mostly in the left hemisphere and a few electrodes in the right amygdala and hippocampus, just in case they were put there, although the idea was that the patient most likely had a focus in the left hemisphere. And what we see here is an onset of a seizure here, and many seconds later, almost the same pattern here. So, of course, if we hadn't put this electrode, we would be very happy to say we found the seizure onset here. We put this electrode, so we say, oh, it's here. But of course, is it here or is it somewhere else? And I don't think there's any way that we can be sure. So from a scalp or intracerebral EEG, there is a fundamental uncertainty about the localization of the seizure onset zone. There's no specific pattern to the onset, and onset and spread can look similar. Of course, it doesn't mean that we can't use intracerebral EEG. We have many other clues to indicate that probably we found the seizure onset. Just want to say that from a kind of conceptual point of view, it's very difficult to know that we found a seizure onset. Can the spike onset zone be found, and how does it relate to the seizure onset zone? I want to relate here studies that we've done with EEG fMRI. Of course, the problem is that spikes themselves propagate. But the bold signal measures with EEG fMRI at the time of a scalp spike indicates the brain region with the highest energy consumption at that time. It is the region from which the spike originates before it propagates and reaches our scalp electrodes. Spikes generated in deep brain region propagate to the surface, and their origin can be found. And this is what we've called the spike onset zone. This is the work of Dr. Koo that was published a few years ago. This is an example here. This is a classical left temporal spike here with phase reversal at F7. And what we found as an activation is in the hippocampus, very clearly, in deep mesial structure here. So what happened? What happened really is that the spike originated in the hippocampus, propagated to the temporal neocortex, usually over 20, 30, 40 milliseconds, and became visible on the scalp EEG, because this scalp EEG pattern is something that is generated in the neocortex. It's not generated in the hippocampus because we can't see what is generated in the hippocampus with scalp EEG. But the maximum bold is where the spike originated, which is what we call the spike onset zone. I'll try to demonstrate this a little more, maybe convincingly in this case. This is an EEG fMRI study. This is the scalp EEG. We found this kind of not very good looking sharp waves in the F3, C3, F4, C4 in the frontal central region here, recorded during the EEG fMRI. The fMRI showed a maximum activation in the left anterior cingulate, that you see here. Subsequently, not at the same time, but months later, the patient was implanted with multiple depth electrodes. I just show here one, which was aimed at the anterior cingulate, here one at the posterior cingulate, and many others that I'm not showing. What did we find? We found in this left anterior cingulate electrode, in the deep contact here, the typical pattern of focal cortical dysplasia, these very frequent spikes here, which did not propagate to the superficial contact of the anterior cingulate electrode here. They did not propagate there, or to the posterior electrode, except one time. Here, as you can see here, this spike does propagate, shows the sharp waves here in the neocortical contact and in the scalp EEG that we were recording at the same time in this particular study, showing exactly the pattern we had seen during our EEG fMRI study. Here we have a delay of about 20 milliseconds between this spike and the neocortical spike. So when we use this event to do our EEG fMRI, was the propagated event, but what we found was the source event. Here the activation, the bold activation, was at the source of the spike. So I'm not saying that EEG fMRI works all the time and that you should do this in all your patients, but again, from a conceptual point of view, if an EEG fMRI study is successful, it can overcome the spike propagation problem, as it can find the region of the brain from which the spike originates, independently of its depth. In a way, similarly to SPECT studies, which, if an induction and an injection is early enough, can find where the seizure started, where the blood flow is the highest, where the energy consumption is the highest. Now, if we can find the spike onset zone, it's nice, but what really want to know is where the seizure onset zone is. So in a study of 31 patients, again done by Dr. Koo, the spike onset zone corresponds to the seizure onset zone defined in the subsequent SEEG investigations. In about a third of these patients, where we had a very clear, isolated, bold maximum, the spike onset zone determines with almost certainty, 93% probability, the seizure onset zone. So just to come back here, they conclude that when we can find the spike onset zone with EEG fMRI, as an example, we can find most likely where the seizure onset zone. And again, this is an investigation of the whole brain. We're not limited, as we are with intracerebral electrodes, exploring only parts of the brain. We investigate the whole brain without any bias towards any region. So next and last question, can HFOs indicate with confidence where the epileptogenic zone is? The advantage of fast ripples, which are these very high frequency oscillations in the 250 to 500 hertz range, is that they hardly propagate. In a study on HFO networks that was done by González Otarula and published a few years ago, 15 patients with SEEG, 0.3% of all channel pairs, all possible channel pairs, showed fast ripple propagation. All these channels involved only 5% of channels, just to show that fast ripples hardly propagate. Now, they have been considered a specific but insensitive marker of the epileptogenic zone because they're often absent in a typical 10-minute EEG analyzed when people analyze HFOs, because it takes a long time to analyze HFOs, and typically we don't analyze a long time. And very often in these 10 minutes, we have very few fast ripples. Then we don't know what they mean. So this is a study of Dr. Nivalayanen that was published a couple of years ago, where we looked at 43 patients with SEEG. Fast ripples were automatically detected during the whole night. So rather than using 10 minutes, we used the whole night after exclusion of artifactual sections. What we used as a predictive measure was that more than 60% of fast ripples had to be in the resection cavity. In other words, we co-registered electrodes and the subsequent resection and looked if most of the fast ripples were in the regions that were resected. And with these measures, we could predict surgical outcome with a very high accuracy level. So fast ripple resection ratio could be a good predictor of outcome. And there was an interesting secondary result to this study, which was that if there was no channel with a high fast ripple rate, not at all in the study, in which we defined as less than 6 per minute, surgical success was very unlikely. And we concluded that this probably because implantation has missed the epileptogenic zone altogether. Again, fast ripples do not propagate. If you don't record them, it's because you're in the wrong place, most likely. So what we had called before lack of sensitivity of fast ripples, because in many patients we didn't find them or find very few, may actually correspond to their ability to indicate a poor SEEG coverage, something that has not been very systematically evaluated before. So what do we conclude from this? A very quick overview, of course, necessarily a very quick overview of spatial relationships between the events we're talking about here. Each event type has its own spatial properties requiring specific approaches. If we want to find where seizures start, we need good electrode coverage because we have to be sure we're close to the seizure onset. However, we're always left with the fundamental uncertainty because seizures propagate, and they can propagate from unexplored areas. The spike onset zone, on the other hand, can sometimes be found with EEG fMRI, which explores the whole brain non-invasively. If a spike has propagated to the scalp, if the spike has not propagated to the scalp, then we can't do the EEG fMRI study, of course. So this is definitely a limitation. But the spike onset zone is very often corresponds to the seizure onset zone. So this is a way of finding it. The fact that fast ripples do not propagate make them a solid marker when they are present. And it may be that an absence of fast ripples indicates that the epileptogenic zone was missed. And really, as an overall conclusion with respect to spatial relationship, we have to remember that each event type provides its spatial definition of the epileptogenic region. Each has to be interpreted with its strengths and its weaknesses to build an understanding of this region. As overall conclusions, it's interesting that we call interictal phenomena. We call HFOs and spikes interictal phenomena because we define them, we say they're between seizures. It's like we don't give them their own identity in a way. We just call them as what matters is the seizures, and then you have these things that occur between seizures. But I would like to convey the idea that they are events on their own, and they're not to be defined exclusively with respect to seizures. Seizure spikes and HFOs are manifestations of abnormal brain tissue. We tend to view seizures as the key phenomenon and interictal events as subservient to them. We need to consider seizures, spikes, and HFOs and other interictal events that I have not mentioned that have different mechanisms of generation, consequently affected differently by intrinsic and extrinsic factors, as I hope I have convinced you of with this few rapid overview. It's interesting to try to understand the relationship between the three phenomena and possibly to use some of them as biomarker for others. But there's really no reason to expect that they all fluctuate in synchrony and that there is perfect spatial match between them because they are fundamentally different phenomena. So I want to thank you for your attention and take the opportunity to advertise this workshop on HFOs. Doesn't want to go back.
So thank you for a very enlightening presentation. We will, at the end of the symposium, please make sure you remember your questions. We will have a question and answer session at the end, and we like controversy, so we are looking forward to that. So our next speaker, unfortunately, cannot be here for very good reasons. Her name is Julia Voskopnik, and she is a postdoctoral fellow working with Sean Pass in the Gladstone Institute and the University of California in San Francisco. She is studying the mechanisms of seizures in developmental and neurodegenerative disorders. She also worked with Eric Robertson about network dysfunction, actually in Alzheimer's disease and Dravet syndrome. We also want to mention that she is actually from the Ukraine. And while we are sitting here all, I think we should think about all the people in the Ukraine who are undergoing a terrible time and are really negatively affected by the war. So she is devoted to raise money and awareness about suffering in the ongoing war. And she is gonna enlighten us about basic mechanisms, what a seizure is.
Hello, everybody. It is my absolute pleasure to present to you today my talk titled, How Are Seizures Defined at the Microscopic Level, from the cell to the microcircuit to the live animal. And I do not have any disclosures today. I would like to acknowledge my research mentor where I'm doing my postdoc, and her name is Jean Paz, and her lab focuses on uncovering the neural basis of the epileptic seizures and demonstrating the possible methods of predicting and arresting seizures. And Dr. Daniel Lowenstein, he's a clinician epileptologist who is educating thousands of medical students and clinicians around the world on seizures and epilepsy. And learning objectives for today is to describe cellular and microcircuit underpinnings of seizures in live animals. And I want to start with an EEG recording and what we actually see when we record EEG. So according to Astra Brand's best estimates, the brain fires about 86 billion to 17.2 trillion action potentials a second. And then EEG let us see some of that activity. And what I call this is a visible tip of the iceberg of the enormous number of processes that is happening in the brain. And the first EEG recording has been done by Dr. Hans Berger. And he was a German physician and psychiatrist, and he was trying to study telepathy. However, during those research studies, he figured out how to record EEG from human cortical neurons. And here is a rudimentary setup that he had to place the cortical electrodes on patients and record their activity. And here you can see his son and the electrical activity that is being recorded from him. And this was the first EEG from a human patient that was ever recorded, and it was recorded in 1924. And actually, this top EEG trace and the bottom, the time trace, was not actually published. However, in 14 manuscripts from 1929 to 1938, Hans Berger described the electrical activity of the human brain for the first time. So the question is, how do electrodes of the skull pick up the electrical activity from the underlying cortex? So let's look below the tip of the iceberg to the cortex underneath the electrodes, and let's figure out what is happening as the cellular basis of the EEG. And the best description of the cellular basis of EEG was actually provided to me by Dr. Dan Lowenstein and his series of lectures on seizures and epilepsy. And in here, how he describes it, we have an ensemble of 6 neurons, 3 on the left and 3 on the right. And then we have to understand that these are cortical projection neurons with their axons actually going down towards the brain, and the dendrites projecting towards the scalp of the brain. And here I'm drawing with the horizontal line a cortical surface with 2 cortical electrodes placed on top of them. So the 3 neurons on the left are receiving the axons from the thalamus, from the brain, and these axons are actually projecting onto the proximal side of these neurons. The 3 neurons on the right are receiving their axons from the contralateral corpus callosum, and they're synapsing on the distal parts of the dendrites. So let's consider what is happening when the electrical activity travels through these axons, and the excited postsynaptic potentials, or EPSPs, are occurring in these proximal dendrites first. So first we have sodium ions that are flowing into the proximal dendrites, and when we have a positive current flow into the dendrites, we have an extracellular negative current or charge accumulating in the extracellular milieu. So that is actually creating a sink. And going back to the electricity basics, we know that where there is a sink with a negative charge, there is actually a source with a positive charge, in our case, actually being depicted here at the distal dendrites. And when we have a source and a sink, we have the electrical activity traveling from the source and the sink to the sink. And the summation of this electrical activity is actually what we are seeing and what we are depicting with our EEG electrodes. And in our case, this positive charge at the distal tips of the dendrites is actually being recorded as the movement of that positive charge towards the sink as a downward shift on the EEG. Similarly, when we have an EPSP or excited postsynaptic potential traveling to the distal parts here on the neurons on the right, we have sodium ions flowing into the distal parts with a negative charge building on the distal dendrites, creating a sink, and the proximal parts have the source. So we have an opposite charge flowing from the source to the sink, towards the cortical surface. And when we see that the charge flowing from the source to the sink, we have an upward movement of the EEG happening. So in here, this is a very basic and simple understanding of what an actual EEG is and what are those all the squiggly lines that we're seeing every single day reading our EEG traces. So the summary of this very simple cellular basis of EEG is that these are large projection neurons in the cortex, and they have similar orientation. And the inputs, for example, EPSPs, among others, cause the flow of ions and produce the current sink and current source. And the summation of the electrical activity in these groups or circuits of neurons is detected by the scalp electrode. So then the question is, what actually causes seizures? And here I showed you what Hans Berger presented was the normal activity of the brain seen on EEG, but we also use this EEG activity to detect seizures and actually eventually diagnose epilepsies. So when I talk about what causes seizures, I'm not thinking about genetics or trauma or idiopathic causes. I talk about the biophysical properties of the neuronal network. So it is pretty much accepted in the field that network hyperexcitability and hypersynchrony are the causes of seizures. And some of the factors that are contributing to the hyperexcitability and hypersynchrony are the intrinsic and synaptic properties of neurons, the input from other neurons, the effect of the glial cells on the network, among others. So let's take a look at some of the seizure examples. And one of the most studied epilepsies in the field and in our lab is the Dravet syndrome epilepsy. And a lot of people want to understand the causes that underlie the seizures in Dravet syndrome patients, because these patients are still very hard to treat, and getting rid of their seizures is problematic. So figuring out how this, what we thought would be a simple loss of function of sodium channel NaV1.1, actually leading to very complex seizure phenotypes in these patients. So as I mentioned, Dravet syndrome patients have a complex seizure phenotype, and they include both convulsive and non-convulsive seizures. And in our lab, we wanted to focus on the non-convulsive seizures. And with a collaboration with Maria Roberto Cilio, used to be at UCSF and now stationed in Belgium, a phenomenal physician scientist, she recorded these non-convulsive seizures in Dravet syndrome patients. And here on the left, I'm showing you the montage of the electrodes placed on the human scalp to detect the electrical activity. And here in the middle, I'm showing you how the actual human seizure looks like with an EEG from those two differentials of electrodes. And what you can see in here as an inset is that these are spike and non-typical spike and wave discharges that have higher frequency component in addition to a slower oscillation. And on the bottom, you can see the spectrogram showing the frequency components of the recorded seizures. And then here I enlarged or expanded the EEG showing epileptic activity that is characterized by the sequence of these polyspikes that are overlaid on the slower oscillation. And here on the left is the spectral density of the seizure, of this non-convulsive seizure, shown in the middle. And the peak fundamental frequency is depicted as 5 Hertz, but it can vary across the different cortical regions for the same seizures. So now to understand what circuits, microcircuits, and neurons might be responsible for these seizures, we had to move into an animal model of Dravet syndrome. And the animal model for the Dravet syndrome that we have chosen is in SCN1A knock-in animal model that has a loss of function of NAV 1.1. And a brilliant postdoc in our lab, Stephanie Ritter-Mackinson, performed the ECOG implants in the somatosensory cortex on the left and right, denoted as 1, and the visual cortex in these animals. And here I'm showing you the ECOG of the both somatosensory cortices with the mouse seizure, very similar to the one that the patient had. These are non-convulsive seizures, and here in the inset, you can see the magnification of the ECOG with the polyspike overlaid on the slower oscillation. And on the bottom, you can see the spectrogram showing the spectral frequency components of the recorded seizure. And similar to the human seizure, here I have an enlargement of the ECOG of these polyspikes from the 2 locations of the somatosensory cortices. So then here I also have the power spectral frequency peaking at 6 to 7 hertz in these seizures. So the question then is, what microcircuits are responsible for the non-convulsive seizures? And for us to really figure that out, we wanted to first identify what microcircuits might be responsible by looking at where the SCN1A transcript was highly predominant. And looking at multiple microcircuits, we figured out that SCN1A was highly predominant in the thalamus. So we have started looking at the thalamic recordings from these mice as well. So for that, Stephanie has implanted the thalamic optrode, here shown in orange on the scalp montage. And this was an electrode that was tethered into the thalamus of these mice. And what Stephanie has seen is the multi-unit activity, or MUA, of the thalamus was actually coinciding with these non-convulsive seizures in these mice. And then because the thalamus has multiple nuclei, she then wanted to figure out what is happening in different nuclei, and she focused on the ventrobasal nucleus and the NRT nucleus. So ventrobasal is the somatosensory nucleus of the thalamus, and the NRT is the inhibitory nucleus that's connected to the ventrobasal nucleus and the somatosensory cortex. And on the right, you can see the orange activity, the multi-unit activity of the NRT, and the multi-unit activity of the VB is actually phase-locked with the polyspikes that is detected in the ECOG for the somatosensory cortex. So then the question is, might these cells of the VB and NRT be responsible for the non-convulsive seizures? And to figure that out, we have to go back and look at what neurons we're actually looking at. And to remind you, we started with a live animal, and here we are showing the scalp of a mouse with multiple electrode placement. And then we moved to the circuit where we're studying the circuit between the somatosensory cortex and the thalamus, and VB thalamus and the NRT thalamus. And then there's a microcircuit within the thalamus connecting the VB thalamocortical neurons and NRT inhibitory neurons, and both are interconnected with those projection cortical neurons that I started my talk with. And then here you can see kind of a simplified version of how this microcircuit looks like. So then to really figure out how the microcircuit is involved in these animals, what Stephanie has performed is she moved into slices of these animals, and she has recorded the activity of the thalamus and this microcircuit itself, placing kind of like a fork-like probe with multiple electrodes onto the thalamus of these slices. And she has recorded the activity of the wild-type slices and Dravet syndrome slices. And what you can see in orange, that the evoked or induced activity in the Dravet syndrome slices is highly increased, both the bursting and the duration of this burst. And here I have it quantified as the oscillation duration is increased and the burst number is increased in this microcircuit of the thalamus. So then let's look a little bit closer to the microcircuit consisting of thalamocortical neurons and NRT neurons, and figure out why hyperexcitability in slices is happening when we record field activity in these in these slices. So to do that, Stephanie first patched electrophysiologically the thalamocortical neurons, and she figured out that nothing was wrong with the electrical properties of these neurons, and that they were projecting normal inputs on the NRT neurons. However, when she patched the NRT neuron, what she has figured out that hyperpolarization induced action potential firing, or this rebound firing, when she provided a minus 60 picoamp hyperpolarizing current to these neurons, actually induced increased activity of these neurons, quantified here on the right as the number of action potentials increased in the Dravet syndrome NRT neurons. So what was underlying this hyperexcitability? And there are a couple of things that can induce this type of rebound hyperexcitability of NRT neurons. And the first suspect was the T-type calcium conductances or currents, and they were not different in these NRT neurons. However, the next one was the low threshold T-type calcium and calcium activated potassium current, small potassium current, or abbreviated SK. So SK currents actually were dramatically decreased in the Dravet syndrome NRT neurons, shown here in red. And when quantified, SK current density was tremendously decreased in these NRT neurons. And actually, the transcript level of the KCNN2S was decreased in these mice as well. And the KCNN2S is the main component or subunit of the SK2 subtype in the NRT. So then the obvious question was, can boosting this SK current fix the seizures or these non-convulsive seizures in these mice? So to figure that out, what Stephanie has done is she provided the local and systemic treatment with the SK agonist called EBIO, which stands for 1-ethyl-2-benzymidazolinone. And when she has provided either local or systemic EBIO treatment compared to the vehicle, they have tremendously reduced the non-convulsive seizures that were detected on ECOG, and also the multi-unit activity in the NRT. And those arrows in the EBIO treatment in the MUA of the NRT that are pointed with the arrows are actually not inducing any of the epileptic activity shown on the ECOG. So it was very interesting to see that this EBIO treatment or pharmacological treatment work in these mice. But then we wanted to ask a bigger question whether manipulating the microcircuit itself can reduce or remove these non-convulsive seizures in these mice. And to do that, we have used optogenetic approaches where the unilateral activation of the SSFO, what stands for the step function opsins, was used. So the activation of these opsins with the optogenetic manipulation of the VB thalamus, which induced the VB from firing from the bursting mode into the tonic mode, was able to actually remove these non-convulsive seizures in these animals. So in here, what you're seeing is the ECOG trace from both the contralateral and the ipsilateral somatosensory cortex and the multi-unit activity of the thalamus. All have the non-convulsive seizure signature gone after shining the light and activating these opsins. So here in the spectrogram, you can see an absolute non-convulsive seizure interruption in these mice. So then, going back to the title of my talk, how are seizures defined at the microscopic level, from the cell to the microcircuit to the live animal? What we have shown in here, that first we observed in human patients these non-convulsive seizures that we verified were present in live animals. Then we moved to the circuit between the cortical and thalamic nuclei, and then moved to the microcircuit of the thalamus. And we focused on the specific neuron, and then we figured out the neuronal properties that were underlying these non-convulsive seizures in mice. So the question is, can we disrupt other thalamic circuit-driven seizures? And that is something that I'm focusing my work in John Paz's lab right now. And I'm studying two different types of neurodevelopmental disorders. And the first one is the SLC6A1 or GAT1 related disorder. And the second one is SCN2A or NAV1.2 related disorder, to figure out whether disrupting the thalamic or aberrant thalamic activity can get rid of seizures that are present in these neurodevelopmental disorders. And highlighted in here, I have the SLC6A1 related disorder with a montage of what electrophysiological activity I'm recording in these mice. So I'm recording the somatosensory and the motor cortices, the hippocampus and the thalamus in these mice. And first I record them in the NREM sleep and REM sleep, and also the awake periods. And what you can see that in the NREM, there's nothing much happening in these mice. However, during the REM sleep, first I have in A denoted as the normal activity that is happening in the motor somatosensory cortex, in the L4 and L5 layers of the cortex, the hippocampus and the thalamus. And then, but the B portion of the REM sleep, actually in the M1, a little bit in the S1, shows this violent activity in the M1, this epileptic activity of the non-convulsive seizure. And it's actually phase locked again if you look at the bottom two traces with the thalamic local field potentials. So if you look closer at the A and B, now I have the normal activity with now looking at the EEG of the M1 and S1 and the multi-unit activity of the thalamus. And if you look at B with those two downward shifting waves or waveforms of the spikes of the beginning of the seizures, preceding that, we have the thalamic bursting that is happening. What I'm also studying is the how these different vigilance states, the NREM, REM, and the wake sleep present with different seizure types in these two different disorders. And hopefully this work is in progress, and I will be able to share the results of this work and whether the changing the activity of the thalamus in these two different disorders is able to remove the non-convulsive seizures in these animals as well. So altogether, impact on the clinical care and practice is the understanding of neuronal and its microcircuit underpinnings leading to seizures is a key for effective treatment of the seizures. And I hope that these findings suggest that the thalamus can be an important target to treat various neurodevelopmental disorders with the data that I have shown to you today. And with that, I would like to thank everybody. And I look forward to answering your questions at the online on-demand sessions of the AES. And thank you very much.
Thank you. That was very informative. I guess we are going after the thalamus in the near future. With that, we will learn about more animal work. And actually, the next talk has this nice title of mice, rats, and men. And what do we have in common? I think this is really a deeply philosophical question. And this is presented by Jana Veliskova, who is also cannot be here, unfortunately, today. She is a professor of cell biology and anatomy in neurology at New York Medical College in Valhalla, New York. She also trained in Czech Republic and back then Czechoslovakia in Prague. And she has a PhD in neurophysiology from Charles University in Prague. And her long-term focus of her research is studying molecular mechanisms involved in regulation of neuronal excitability in the epileptic brain, with the goal of developing mechanism-based disease-modifying therapies, prevention of epilepsy, and its behavioral comorbidities. So we look forward to her talk.
Good morning, and please accept my apology that I cannot join you in person today. We had to cancel our trip to Nashville last minute because of unresolved family illness. I have nothing to disclose. And at the end of this presentation, the audience should be able to compare semiology of seizures in humans and rodents, and also discuss translational value of rodent seizure models. Here I will discuss the common features of seizures in rodents and humans, but also differences which need to be considered for translational purposes. My intention is to provide some examples of commonly induced acute seizures, as well as spontaneous seizures, which represent the true epilepsy, and highlight advantages but also limitations of rodent models. I hope that this presentation will provide some tools for interpretation of laboratory animal data. What the rodents and humans do have in common is the ability to induce seizures acutely, as well as presence of spontaneous seizures or epilepsy. In humans, acute seizures associated with poisonings by different neurotoxins are known for centuries. We all know about typical seizures induced by strychnine, which are associated with violent muscle contractions, opistotonic posturing, and characteristic expression in face called rhesus sardonicus. But the strychnine has been used historically as rodenticide, and human accidental as well as intentional poisonings have been repeatedly described. Currently, these poisonings are not so common because strychnine is now tightly controlled and only licensed workers can handle rodenticides containing strychnine. Recently, however, there is a new wave of accidental by also intentional poisonings by naturally occurring as well as synthetic neurotoxins that have convulsant effects, especially by antagonizing the GABA-A receptor currents. I will focus a little bit more on this type of seizures because some of them have been also used for iatrogenic purposes. And most importantly, they serve as the classic acute rodent seizure models. Another example, which I will discuss, are the seizures induced by activation of glutamatergic receptors, specifically of the kynic acid subtype. There are two reasons for this. First, because of the known accidental poisoning cases with domoic acid, which is a kynic acid receptor agonist, which happened in humans 35 years ago after ingestion of mussels containing algae-producing domoic acid. And second, the use of these agonists produce the widely used model of temporal lobe seizures, as well as temporal lobe epilepsy in rodents. In humans, acutely induced seizures represent a common treatment for some psychiatric disorders, such as depression or schizophrenia. And this peculiar treatment has been introduced by Hungarian physician Ladislav Meduna. He first experimented with camphor-induced seizures in 1934, and he was convinced that the therapeutic agent is not the camphor, but the seizures. Later, he became aware of water-soluble metrazole, which is also called pentylenetrazole. So he quickly switched to more convenient substance for intravenous administration. In 1957, the convulsive inhalation anesthetic Fluorotil, or also called Indoclone, became available and was also used to relieve these psychiatric disorders. Although both chemicals have been replaced by maximal electroshock-induced seizures, there seem to be second thoughts, especially in favor of Fluorotil, which in comparison with the maximal electroshock seizures has lesser side effects, especially on the retrograde memory. Nevertheless, the main mechanism of action of both metrazole and Fluorotil is via the antagonism of GABA A receptors, so the blockade of the chloride currents. And the seizures elicited by both drugs have characteristic sequence. The first signs are the myoclonic twitches, which progress into clonic, and finally the tonic-clonic seizures. Both agents became also popular in laboratory in late 40s and are used as a model prototype of generalized type of seizures in both mice and rats. And the seizure progression in rodents is very similar to what we see in humans. Similarly, the semiology of a popular rodent model of temporal lobe seizures induced by canic acid resembles the syndrome of poisoning by domoic acid in humans. Both these agents activate the canic acid receptors to elicit seizures. Initially, the seizures start as limbic type of seizures. In humans, symptoms include a fixed stare, lip smacking, while in rodents, the limbic seizures present with freezing, chewing, and head bobbing. Basically similar semiology as in humans. In both humans and rodents, the seizures later evolve into clonic seizures, and eventually status epilepticus develops, which is commonly observed in rodents, but also described in humans. Although in humans and rodents, these types of acutely induced seizures share many similarities, there are some differences in response to these agents between the two. In general, humans are highly sensitive to convulsant agents, and seizures occur following several-fold lower doses in humans than those necessary to induce seizures in rodents. The therapeutic endpoint in psychiatric patients is a rapid induction of tonic-clonic seizures. These seizures are self-terminating, and the patients have generally few side effects with mild or no long-term consequences. The therapeutic procedure involves multiple seizure induction, usually administered 2 to 3 times per week, but sometimes even daily seizures are induced with up to 30 courses of the treatment. In contrast, in rodents, doses which lead to rapid progression of seizure syndrome to tonic-clonic seizures are associated with high mortality. Further, repeated administration of metrazole in rodents in subthreshold doses have kindling effect. And regarding the fluorotil, repeated fluorotil-induced seizures would eventually lead to development of spontaneous seizures, or the epilepsy, in mice. Similarly to metrazole and fluorotil, humans are significantly more sensitive to domoic acid poisoning. The classic syndrome induced by domoic acid poisoning in humans, besides the seizures, also includes vomiting and, most importantly, amnesia, which is most pronounced in older patients. Interestingly, in rodents and other animals, the hallmark of domoic acid poisoning, besides the seizures, is aggressive behavior, which has not been described in humans. After domoic acid seizures, the histopathological findings are generally similar in humans and rodents. In both species, the hippocampus is the leading structure with the most prominent damage, but the high sensitivity of humans to this toxin compared to rodents is evident after more detailed investigation. In humans, the neurotoxic lesion involves all hippocampal pyramidal cell regions, from the CA4 up to the CA1 and subiculum, with basically complete loss of pyramidal neurons in all regions except some sparing in the CA2 region. In contrast, in rats, the neurotoxic lesion in the hippocampus is more subtle, less affecting the CA3 region and more affecting the CA1 region. The kynic acid model represents the most common model for temporal lobe epilepsy. This model involves status epilepticus induced by kynic acid, representing the initial precipitating injury, which after a latent period of epileptogenesis leads to development of spontaneous seizures. The acute seizures induced by kynic acid mainly originate from the hippocampus and overlying cortex, and this is similar to humans. EEG recordings show an early onset of hippocampal-cortical epileptic discharges, corresponding in behavior to typical limbic type of seizures, characterized by freezing, chewing, head bobbing, and some automatisms, such as scratching. These seizures share many similarities with the seizures in patients with temporal lobe epilepsy. Also, the hippocampal lesion in rodents shares several similarities with the human hippocampal sclerosis, which affects the hilar region as well as the pyramidal neurons in the CA3, CA1, and the subiculum. What, however, is different is the generalization of seizures. In rodents, generalized seizures present as clonic seizures, The spontaneous seizures later on are also clonic seizures. On the other hand, in humans, the patients with temporal lobe epilepsy evolve into the tonic-clonic seizures, which do not present in rodents. Indeed, these differences in seizure-induced damage, as well as the generalization of seizures, may be due to differences between the human and rodent brain. What are some noticeable structural differences between the rodent and the human brain? First, we have to keep in mind that the rodent brain is lissencephalic, but the human brain has gerification. Thus, for example, here is the arrangement of the primary motor cortex. The human motor homunculus is spread over the precentral gyrus, and the individual muscle group organization follows the dorsoventral direction. In contrast, rodent motor ratenculus rather follows frontocaudal organization, and moreover, the proportion of motor association cortex to the primary motor cortex is much smaller compared to humans. There are also significant differences in the limbic cortex between rodents and humans. In rodents, the limbic cortex comprising the perirhinal and the entorhinal cortices and the hippocampus occupies a large portion of the cerebrum. The hippocampus spreads from the dorsal to ventral region of cerebrum. And that is not the case really in humans. In humans, the hippocampus is confined along the inferior horn of lateral ventricle, and the perirhinal and entorhinal cortices reside in the parahippocampal gyrus, located on the ventral part of the cerebrum. Developmental differences also play a significant role in data interpretation. My training was in Nico Mouchet's lab, and he was one of those who always emphasized that the immature brain is not a small version of an adult brain. One of the important differences in neural development between the humans and the rodents is represented by the relatively late formation of neural tube in rodents. While in humans, the neural tube starts to form already during the first months after conception, the rodents have the neural tube formed in mid-gestation. Thus, many neural developmental events that are generally finished in a full-term human newborn are in fact ongoing during postnatal development in rodents. So, for example, the gliogenesis mainly happens in humans prenatally and finishes around the first year of life. But in rodents, the gliogenesis occurs only postnatally. If we roughly correlate the maturation of the central nervous system in rodents to human brain developmental milestones, a 10-day-old rat's brain corresponds approximately to a human newborn. Puberty then happens in the 4th week of postnatal life in rats as well as mice. And a mature rat brain and mouse brain can be considered at about postnatal day 55. Yet, we need to be cautious because equating rodent and human ages based upon a single milestone may lead to misinterpretation. For example, levels of GABA synthesizing enzyme glutamate decarboxylase in the cortex of human newborn corresponds to about 16% of the adult level, which in rodents is achieved approximately by postnatal day 7. On the other hand, similar relative levels of acetylcholine synthesizing enzyme, the choline acetyltransferase, found at birth in humans, are in rats present at about 3rd postnatal week. Before I finish, I would like to share an example of how important is to reconcile the differences between the rodent and human brains. Recently, a French group published a report of successful disruption of focal motor seizures by deep brain stimulation of internal part of globus pallidus. This report immediately took my mind 40 years back when one of the finest neuroscientists, the great mentor and most important great human being, the late Karen Gale, published her seminal discovery when she identified the substantia nigra pars reticulata as a critical seizure controlling site in rodents. Unfortunately, targeting the substantia nigra pars reticulata to control seizures in humans did not bring such expected success. The reason might be in different organization of the rodent and human basal ganglia. In rodents, the main and only output from the striatum in the direct basal ganglia pathway is the substantia nigra pars reticulata. In humans, while there are some collateral projections from striatum into the substantia nigra, the main target of striatal projections is the globus pallidus internal part, which does not exist in rodents. And further, differences are in the projections that is evident especially in the pallidothalamic and nigrothalamic pathways. These two pathways differ in the final target thalamic nuclei. So to conclude here, we can say that the seizure semiology in rodents and humans is similar. However, when translating the animal data, we have to consider the structural, molecular, and developmental differences between the two to get the most of the animal models. And because we all know that the best material model for a cat is another, or preferably the same cat. Thank you for your attention.
Thank you for an excellent presentation. Just listening to this, I want to tell yet another story. When I was a young fellow, I went to one of my first AES meetings, and this was a time when all seizures were thought to be cortical. And then, just being curious, I go to a session of Karen Gale, where she talks about this seizure gating in the pars radicularis. And I'm like, why don't the animal people not talk to the human people? And I am glad that now, at this time, we start talking about those differences. And we come back to the humans, and with that, I want to introduce Patrick Chauvel, who is currently a professor of neurology at the University of Pittsburgh. And he started off actually at Saint-Denis in Paris at the SEG unit, which he directed for a long time, and then went to the INSERM Institute in Marseille. And in France, for many years, SEG was well established before it finally came to the US, and Patrick had no small role into this. He then went to the Cleveland Clinic and also helped us here in North America to be more familiar with the SEG methodology. He has done a lot of good work, which includes the pathophysiology of the epileptogenic zone, a lot of clinical seizure semiology description, as well as cerebral cortex physiology. And he's gonna tell us today, how do we define seizures with intercerebral recordings in humans?
Thank you for this nice introduction. I will try to talk about, what is a seizure? That means, what did I see when I explored inside the brain? So no disclosure. I think that geophysics has inspired, maybe too much in my taste, the seizure onset, spread, and concept. Look at the modeling of an earthquake. It's like a focus, and to describe and to understand the localization, we rely on a number of, station. So I have to. You see, okay. We are recording with stations like electrodes, and we rely on time and latency between what we consider an onset and spread, and we can measure like this latency and conclude about localizations, knowing, like John insisted on, that we are never sure to be close, but we are always sure to be at least a little bit remote. That was the trend of considering what is a seizure. My question is this seismic analogy still valid in humans? For that, I will just try to describe my experience exploring the brain with epileptic seizures. And I will show you, I will explore different seizure types, the medial temporal seizures, asking is it a model? The pericentral, the associations cortex seizures. I will show you how seizure onset to me is a transition, and I will at the end insist on specific features of the high frequency activity, and maybe some attempts about its pathophysiological significance. This is a temporal seizure, at least what we observe when we implant, like here, electrodes, depth electrodes inside the brain, that is SEG. So you can see that here you have amygdala, hippocampus anterior, posterior, entorhinal cortex, and here orbitofrontal cortex, insula, and we also explore part of the insula, basal occipital cortex, and posterior cingulate. These to me are typical mesial temporal seizures, and you can see that here you have a preictal spiking. I use this term, it's an open term, it's not interictal, it's preictal. And here you can see not all the electrode, but in several structures of the medial temporal lobe, you have a high frequency activity. You can see it simply by visual analysis. And propagation. Propagation, which is early in the mesial temporal lobe here, and late in the lateral cortex, perisylvian cortex, orbitofrontal cortex, where you have the electrodes. And so it's clear that when you measure, that we did in the past with Fabry-Swendling, the correlation, that means the coupling or the uncoupling between these different areas, you can see that the correlation between these areas is increasing with time. And at the end, you have a high synchrony before seizure termination. So a model of mesial temporal structures could be like this, a background activity with some interictal spike, preictal activity, preictal spikes, seizure with fast activity, and decreasing frequency. In the past, with Fabrice Bartholomé and Fabry-Swendling, we could show that here is the correlation at this different type of the seizure, and you see that the correlation between the coupling here between amygdala and entorhinal cortex increase before and after the rapid discharge. But more importantly, there is a frequency locking at the beginning of the fast frequency. That means a decreased correlation, but a frequency locking at the onset of fast activity. So, if again we're trying to now describe in detail, seeing that time is important, I agree, Jean, seizures propagate. But you have also to consider the spectral content, the frequency content of what we record. And first you can look at this. You have a propagation of spike, preictal, but clearly it's not an epileptic marker. It's just propagation of the spike at this time. And if you look a little bit later, you will see that there's a flattening, that means a disappearance of the slow frequency before late propagation remotely from the seizure onset. So this spike here look different. How are they different? So we'll use this tool, which is a time frequency analysis of the signal in different structure here, amygdala, anterior hippocampus, posterior hippocampus, entorhinal cortex, just to describe the evolution in time of the spectral content and the frequency energy in each of the bands. So what we see in these seizures very clearly here, that you have a progressive synchronization of spikes and a transition from the preictal spike to the spike fast activity. You can see here how the frequency content follows what is the frequency content of each predictable spike, which is not only a slow activity, but at the same time a very high frequency activity. So the phenomenon is double. You can see here that the amygdala presents a double fast narrow band, which follows the frequency content of the predictable spikes. Interesting. Here, you see that you have in the hippocampus, anterior and posterior, a fast narrow band which follows the last spike, high frequency activity, with a decreasing frequency. And here, in the hippocampus, both hippocampi, suppression of low frequency activity, which was content in the predictable spikes. And here, no high frequency activity, in this case in the entorhinal cortex. And here, you have in the hippocampus and entorhinal a rebound and a late propagation. This is why, with Fabrice Bartholomé and Fabrice Wendling, we found that fast activity is a natural marker of an epileptogenic zone in the medial temporal of epilepsy. Considering that you can mark in studying the relation between the fast activity and the suppression of slow activity, the flattening, you can define an index and to follow in time the HFE onset, and the time of HFE onset is a measure of epileptogenicity. You see that it's the same pattern as the one we found in the preceding case. Similarly, it's clear that if a case like this, you measure the infraslow activity as is being promoted by Akio Ikeda first at the Cleveland Clinic and in Kyoto, and you see that corresponding very clearly with the onset of the fast and the burst of the fast activity, you have a sharp increase in the infraslow activity. It has been also considered a marker, but not independent on the fast activity. So is this mesial temporal seizure model universal? That's an important question. In fact, we will try to understand more about, take the example of pericentral seizures. This is a typical sensory-motor seizures. These electrodes are in the postcentral and precentral cortex, and you see the other are exploring other parts of the parietal and frontal lobe. Clinical onset is here. And when you look at these bursts, which could be interictal, maybe preictal, and now here the seizure is here, you see that the propagation is totally different from the mesial temporal model. It's like a synchronous propagation. Even if you can have some variation in latency, it's developed in the epileptogenic network with synchrony. Now, if we look in the precentral opercular seizure, similar to what we saw, you see clearly that we are in a very limited epileptologic zone, and you can see we are here in the opercular precentral region, and you see that the transition between interictal and preictal spike is here, with oscillatory spike burst that can happen in this type of cortex. That means in all this sensory motor cortex and also in the sensory cortex elsewhere. And here you have with this left facial contraction synchronized with this burst. You see now you have the same synchronous propagation during this type of seizure. And when you look at the time frequency of this seizure, you can see that after repetitive spike on the same kind of the preictal spike, now if you expand the time scale, you can see that each part of this burst of seizure is made by a spike in high frequency activity, and in this case, some harmonics, because we are on a pulsating mode, and in this pulsating mode, it triggers harmonics. But there is a fast activity here, even if it is lower than in other cortices. In the same patient, that was interesting is that there was a second type of seizures. You recognize the steady interictal preictal activity, but this time it was a fast activity seizures. You see that the transition from interictal to preictal led to, like the spike merge into a fast activity, then a clonic rebound. So you see that the two types of seizures can coexist in the same patient in these cortices, with an early and this time a late propagations in the motor cortex. So that's the second type of seizure. You recognize the pattern, but what is interesting is that it's more similar of what we saw in the temporal lobe with preictal spikes, high frequency activity, suppression of slow activity, and a rebound with a early and a late propagation. It shows that these mechanisms depend of something happening in these regions before the fast activity emerge from the preictal spikes. Let's move now to a different type of cortex, the association cortex seizures. It's different types and even faster activity. And you see here that when we measured, for example, the correlation, that means again the coupling between these two areas of the frontal lobe with preictal spiking, fast activity, and a decrease, you see that we can measure a coupling between the structure, that means like in the mesial temporal lobe, but at the onset of the fast activity, there is a dramatic decoupling, a decorrelation. It's not synchronous at this time, and we have a recoupling before the end of the seizure. So what does that mean? In this patient, you see that the seizures came from this part of the medial cortex with preictal spike and fast activity and the spread. And what is interesting, when you stimulate a very limited part of this area of the mesial frontal lobe, you can trigger a seizure exactly the same, and you will see that it is superimposed and it's exactly the same network which is triggered with a very limited part of the network. That means that the whole epileptogenic network is synchronously activated by a simulation of a very limited area. That is, this synchronization and this network is triggered in the very limited zone here. So, taking advantage of such a case, what's happening at this interictal preictal ictal transition? We took advantage of the case explored at the Cleveland Clinic with Jorge Gonzalez, and it's rare to be in this kind of occasion where the epileptogenic zone is so small that a laser ablation could get the patient seizure-free. So what happened here, where we are quite sure that we were in the epileptogenic zone? Here, the recording I show you is referential. And this is the only part which is discharging. You see that you have interictal activities. In these two leads separated 1.5 millimeters. And now you have interictal activity, and you can see that here and there, it could look like a fast activity, like maybe ripples, but in fact, you see that there is a jitter in the different part of this activity, and this jitter and the same latency explained by the field projected in this electrode the appearance of a fast ripple. And now, the transition between preictal activity and seizure onset is interesting to consider. Here, you see that the latency, you have a small, say, few milliseconds latency. This is a 5-second page. Here you have, again, a latency between these regions and the more lateral cortex of the frontal lobe. And if you measure now the amplitude of this sharp wave after the spike, you see that it increases with time, as always. And when it increases time, just before the onset of the seizure, you see that an emerging fast oscillations, fast activity emerge here and will finally develop here. And this is the transition between the preictal spikes, the emerging of the fast activity, and the development of the fast activity in the epileptogenic zone. At the same time, you can see that you have a flattening, that is a depression of activity in the lateral cortex. And if you don't care, you could think that what we call seizure onset is here. And in fact, seizure onset is there. That means what happens here is not simple. And even if you measure with the 60-second pages exactly the same seizure, you see that the seizure onset is not when the flattening happens, but when the fast activity happens. So you see that we are now in these association cortices, in this situation where you can have, even with distant electrode, quasi-synchronous activity. And when you are, and it's very often out of the mesial temporal lobe, it's a very frequent situations when you are exploring patients, mainly with focal cortical dysplasia in all the neocortices. You cannot rely on latencies. So you are obliged to think about how to resolve the case of these synchronous high-frequency activities. So we explored that a few years ago, and we used the frequency content of these pre-ictal to ictal seizures. And we isolated inside the resection in a population of seizure-free patients a pattern which resembles what I showed you a few slides ago. That means these patterns with preictal spikes generating a narrow band. Narrow band is very important activities, sometimes double, with a suppression of the slow activity. What is extremely important to consider is that I put this word synchrony and diachrony, sorry for the Greek term. It means that the pattern is not recognizable at the onset. It's recognizable and if you consider the totality of the seizures. So that's why the seizure onset time is not sufficient to define an epileptogenic zone. The diachronic aspect is as, I would say, more important. So these transitions of dynamics between the preictal activity to the seizure was developed by Fabrice Wendling in the model of mesial temporal seizures. But also we retrieve some of this element in neocortical seizures. And meaning that the epileptogenic zone signature is a transition, is not abrupt. And now, if you look at different types of seizures, this is a frontal opercular seizure, and you look at the frequency, time frequency pattern. You see that you have relatively high frequencies, meaning here we are around 120 Hertz. And look at the duration. We will show now, with the same time scale, different subtypes of seizures. This is a prefrontal seizure with its time frequency counterpart. You see that the duration of the fast activity can vary, but is relatively long in these seizures. Here, it's an occipital seizure with, you see that the frequency is much lower here and the fast activity shorter. And this is a mesial temporal seizure. Remember, we expanded this but in fact, the fast activity is lower, that means it's low gamma, and is short. And the ventral precentral that I showed you, which can be more spiking and spike and fast, but in fact, when you expand the time scale, you see that the pattern is similar, but shorter with spike, fast activity, suppression than the other one. So, does a universal pattern exist in terms of time frequency? The differences would be the type of high frequency and the duration of the pattern, depending on the cellular organization of each of these cortex. It's an open question. So I will finish by trying to share with you how I see the pathophysiological significance of these observations. In fact, what is interesting, and one of the most interesting to me, is the phenomenon of chirping. Chirping is high-pitched sound by bird. This is a bat chirp. You see, with decreasing frequency with time. And if you look at what we record in the neocortex, we have all this phenomenon, and as in our brain paper, we use a learning machine algorithm, we recognize the pattern when the condition was this decreasing frequency with time. And this was modeled in an excellent paper made by the Fabrice group, showing that they could, this is recorded in a human epilepsy. And you see that the frequency decreased in time and the activity started. And it's a gamma narrowband, chirp-like, near constant amplitude. And this has been modeled by Fabrice Wendling and us long time ago in trying to model the organization of these cortices between pyramidal cells and two types of inhibitory interneuron, the fast and the slow. And in this very interesting paper where they tried to model this phenomenon of chirping, they show the effect of connection strength. In fact, it can be explained by this couple between the fast inhibitory interneurons and the pyramidal cell. And when you study here the connection strength between the pyramidal and the fast inhibitory interneurons versus the feedback between pyramidal, and if you compare with the connection strength between the fast inhibitory and the pyramidal and inhibitory to inhibitory, sorry, it's a little bit complicated, but just to show you that to get this chirping, it's a very narrow band of resonance at a certain frequency. And it has been shown in physics that a positive plus a negative feedback line here is the mechanisms for getting a tunable frequency with near constant amplitude. That is the conditions to remain in this zone, that is the case of our narrowband fast activity, are explained by a kind of balance-imbalance between the feed-forward and feedback between the pyramidals and the fast inhibitory interneurons. And this idea is emerging now. Now we are more and more, I see that in papers of many of our colleagues in UCLA, in Montreal, in Columbia University, that the role of the inhibitory interneurons is considered very seriously. I like this schematic at the end of a brilliant synthesis by Marco De Cutis and Massimo Avoli, showing that, showing that at the onset of a seizure, that is in the rodent that reproduce in humans, here you have the pyramidal neurons and here the inhibitory interneurons. Contrary to what we could expect, the pyramidals are silencing due to the activity of the fast inhibitory interneurons. And this is probably part of triggering mechanisms of the rest of the seizure. And I will, speculate in asking if this time frequency model can be explained by the Descortis-Avoli scheme with, the slow activity and the fast coinciding like this. That would be purely an analogy, obviously. And the last question is, the group of Toronto showed in different papers that reproducing the data in the rodent from a Descortis of Avoli, they saw that if you have, as they call an inhibitory bolus, that in a strong inhibition triggered by the pyramidals, obviously, at the onset of a seizure, it's a post-inhibitory rebound on the pyramidals that trigger the seizure. What I would propose is that the seizure is not there. The seizure is here, because high-frequency activity is here, and the inhibitory phase is triggering what we call the late propagation. So, to conclude, I think that the focal seizure develop in cortical and obviously subcortical systems. And the epileptological structure depends on the system and obviously of the underlying pathology, but maybe less. The ictal patterns are formed by the cortical system in which they arise. Early and late propagation differ between seizure types in their synchrony or asynchrony pattern. I think that time frequency and correlation analysis are used to define the synchronic and diachronic aspect of seizures. A typical time frequency pattern for focal seizure has been identified. Could it be universal? But what is really specific is this narrowband high-frequency activity. It's a tunable oscillatory phenomenon emerging from the epileptal spike. And I am very interested by this new hypothesis, which postulates that this cortical resonance is produced by a positive plus negative feedback between pyramidal neurons and perisomatic fast-emitting interneurons. And I think that the idea raised by the Toronto group about the post-inhibitory rebound would trigger the terminal part of the seizure is also very stimulating. So I would like to thank you, all my co-workers who participate since a number of years to gathering progressively elements that can allow me today to just try to describe what is a seizure in the brain. Thank you.
Thank you, Patrick. Now we come to our last speaker, who also brings us back to the clinic and is gonna tell us about clinical controversies in the definition of a seizure. This is Michael Sperling, who is currently the Baldwin Keys Professor of Neurology and Vice Chair for Research at Thomas Jefferson University and the director of the Jefferson Comprehensive Epilepsy Center. He certainly also needs little introduction, as he is international known, being a clinician scientist, and especially for his work in epilepsy surgery and electrophysiology. He has published over 380 papers, 100 book chapters, and reviews and several books, so he never seems to sleep. And he is well known to us as the current editor-in-chief in Epilepsia. Welcome, Mike.
Thank you. I will bring this symposium home with the last talk, and then there'll be questions that we'll take. I'm going to speak about clinical controversies. And I'm going to raise a few points, one of which is I'm not convinced I know what a seizure is anymore, especially after having prepared this talk. I think there are very discrete electrophysiological events that we have seen beautifully described this morning, but I think our clinical work needs to catch up to the electrophysiology. I have a few disclosures, none of which have any relevance to this talk whatsoever. At the end of this presentation, we'll be able, I hope, to discuss the impact of interrectal epileptiform discharges on behavior, the limitations in the formal definition of seizure, and also discuss subclinical seizures and their behavioral implications. So I'll just show you a video first, because this is what we all think about, and Patrick just showed us beautiful examples in electrophysiology, as did other speakers, of seizures. But this is a 25-year-old man who has given me permission to show the video, I should say. His seizures began at age 8. He was drug resistant. He would have a sense of tingling in his head for 5 seconds, and then be confused. His head may turn to the right, and he may have right arm deviation or not. They would only last 5 or 10 seconds, and these were happening 4 to 20 times per day and night. He had 4 seizures as a child that had progressed to become tonic-clonic, but otherwise they were brief, and I'll show you the video now. He'd failed treatment with many drugs, intellectually quite normal, college graduate, functioning at a very high level. His interictal exam was normal. His interictal scalp EEG had no sharp waves or spikes, for that matter, although there was occasional F3 theta. His MRI and PET were normal. And the video, I apologize to my French-speaking colleagues who preceded me. I'll show you his chapeau de gendarme. And now I have to use my mouse. Whoops, I don't want to do that. So I'm having mouse trouble here. After what's that?
It's running.
Oh, it's running, okay, good. And pause right there. You see his face? That frown, that chapeau de gendarme. Then it's over in the video, and the sound did not work for whatever reason. His scalp EEG and that chapeau de gendarme is classically thought to be a frontal lobe sign. It's been reported with insular seizures as well, probably with connection to frontal lobe, and I'm sure if we study more, we might find other places, but mainly frontal lobe. And what we can see where the arrow shows here is again the ictal onset, and we see fast activity. These are 4 right parasagittal, then 4 left parasagittal, and then some transverse chains. An attenuation of sorts, and then ictal fast activity appearing in the left parasagittal region, maximal at F3. It builds up. This is the next page. We see some evidence of spread, and then abrupt seizure termination. So this is a pretty typical. I'll go back to the start. Again, some attenuation of amplitude, buildup of fast activity, F3 there, some muscle buildup we can see. It evolves and terminates. Typical seizure, it's what we always think of, and there was a behavior. With his SEEG, what he had were continuous rhythmic interictal spikes in this region, which certainly made us think of an underlying focal cortical dysplasia. And then the ictal transition was a little bit like what you just showed, Patrick, in that we see a slight increase in spiking, development of fast activity, and then termination. And in fact, the fast is not quite as fast as you showed us in your examples until the very end of the seizure. During this phase in the middle, he's already displaying his ictal behavior and alteration of responsiveness. And it's very focal, really in just a couple of SEEG contexts. He was operated on, had a fairly restricted left frontal resection, fairly high parasagittal and medial frontal. He had an underlying cortical dysplasia. And actually, I just heard from him a few weeks ago. He's been seizure-free for 5 years right now, so we got the relevant areas that were necessary. So what is the definition of a seizure? And this is sort of an official definition adopted by the ILAE. It makes sense. Bob Pischer published a paper in Epilepsy a long time ago. A transient occurrence of signs and or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Fits it very nicely. We see excessive synchronous firing in the brain during the seizure electrophysiologically. It's a well-defined episode. We may quibble as to when we consider the start. Is your preictal spiking preictal, or is it really ictal? Is some of the postictal suppression truly postictal, or does that represent an ictal phenomenon because it's so strongly associated with a seizure? But there's a discrete event with the margins perhaps a little fuzzy and a clear associated behavior, right? Straightforward. Now, this is an example I'll show you of a patient of mine who has an RNS in place. She has seizures that cause flashing lights in her left visual field. And prior to RNS, some would progress to transient unresponsiveness. Post-RNS, she has had none with unresponsiveness. So the RNS worked very nicely, although she would still have occasional focal aware seizures where she would see flashing lights. This is the sort of a window of time from May through September of 2021, and we can see bursts. These are long detections. We see bursts, and you'd say that she goes for extended periods of time without any activity at all, but in fact, this is when she doesn't bother to upload data, and then shortly, but you can tell when visits are due because then she begins to upload data a month or so before her visits with me. So at least I have a little information. So we see these long detections. Moving forward, this is a sample of her ECOG library, and I'd like to give a shout out to NeuroPace for, I think, developing a very efficient and effective way for us to look at a large amount of data quickly and easily. It's a very nice example. We can look here, you can see we have 18 EEG segments over the period of a number of days, and you can count in here and see very easily in this display 11 seizures. Each one of these thick blips is a seizure. If I were to do a close-up on it, here's one of them. We can see more nicely. This is a 90-second period. You can see the start of the seizure, the fast activity, the envelope of activity, the change in frequency, and then the termination. And for those who want to see it a little more closely, here's the start of it. Again, beautiful buildup of ictal fast. It's really highly restricted. Unfortunately, there are 2 electrodes, and one of those broke at the level of the entry zone, so we only have recording from 4 contacts and 1 electrode, but we see the seizure beautifully. So again, to go back, we saw 11 seizures in 2 weeks. We can look at them closely, but there was one problem, and that was that when I saw her in September 2021, she had said she'd been seizure-free for 8 months. She hadn't had a single seizure at all, though in a 2-week period, we saw 11 electrographic seizures. Coincidentally, a week after she saw me, she then called me to report that she had had a seizure finally. So the lack of clinical seizures was also verified by her family. They'd been there when she had them. She'd not said anything to them. And again, these are purely subjective symptoms of flashing lights. And I'm in the office, and what do I do when I see her? She says she's been seizure-free for 8 months. I see 11 seizures in the preceding 2 weeks. Do I treat the electrocorticography or treat by reported symptoms? And according to our official definition, this patient is not experiencing seizures. The definition of seizures by the ILAE is that she's seizure-free. If we do investigational drug trials and companies want to register them for approval of their new drug or their new device by the FDA, all that is counted are clinical reports of seizures. We know that patients often miss seizures, usually miss some seizures. Some patients miss all of their seizures, but we take the clinical report as gospel. Yet now when we have good tools with long-term chronic intracranial EEG, we see the clinical report is a little dubious because there is a discrete electrophysiologic event we would all agree is a seizure. So the implication is not only scientific and with regard to medical treatment, but emotional, because the term itself is bothersome. If you told me that I had just had a seizure, I'd be upset. When I told this patient that her electrocorticography did show electrographic seizures, she was a little disturbed, or more than a little disturbed, and I tried to allay her concerns that if it doesn't cause symptoms, it doesn't bother her, it probably shouldn't bother me, and we shouldn't alter her therapy. But I don't know that that's correct. And the diagnosis carries implications about medical risks, there are psychosocial risks, there are educational and employment effects. If someone has a seizure, like me, they could probably be a neurologist, but maybe not be a neurosurgeon. That's one example. So it makes a difference. There's an increased risk of injury and death when people have seizures, that is clinical seizures. We know that there's excitotoxicity with neuronal loss and brain impairment. Do these electrographic seizures produce that? I don't think the answer is known fully. There's psychiatric comorbidity with increased risk of depression and increased risk of suicide for that matter. And does that apply to subclinical or clinical or both? We only know people who report clinical seizures. And there's increased risk of morbidity and death if they have additional non-neurological and neurological diseases. So our conventional interpretation of the diagnosis, we see seizures, we should treat them to prevent seizures and their adverse effects. But what is a seizure? And that is our fundamental problem. So the problems with the definition: where do subclinical seizures, as I showed you, fit in? Do they merit treatment or not? This is a real clinical dilemma. What about excessive or synchronous neuronal activity that's abnormal but is associated with neurological signs but are not the electrophysiological signature of seizures? I'll show you these interictal spikes and ripples. And then what about behaviors that look like seizures but lack electrographic correlate, for example, that we see in neonates? Do we treat them? Do we not treat them? Is that simply a sampling error? It's a seizure, but we haven't sampled adequately. So are subclinical seizures really subclinical? And our group published a paper back in 1989. My first fellow, Peter Bridgman, was the first author of this. The work was done with Barbara Malamet as well, a neuropsychologist, where we did neuropsychological testing in 2 patients who were having relatively frequent subclinical hippocampal seizures in the left hippocampus, recorded with depth electrode. Neither subject had any symptoms reported. There was no impairment of consciousness. Our neurological testing was fine. Their orientation, motor skills, verbal fluency was fine. However, the rate of recall of a well-learned word list was impaired in one of the subjects during the fast typical spiking. So we could document, if we did sophisticated enough testing, that there was in fact an impairment, a neurological sign. Rate of recall was impaired. So what we considered a subclinical seizure is subclinical only because our testing isn't good enough. But there really is a sign in some of these cases. And maybe some subclinical seizures are responsible for a portion of memory deficits found in people with epilepsy. And maybe they merit treatment on that basis. So we showed an alteration of performance. It required sophisticated testing to detect it. And again, maybe what we mean by a seizure is an obvious change. But that's a very unsatisfying definition. So do all seizures need to be prevented or treated? And this is the other issue. We really have a plethora of seizure types, from major convulsive tonic-clonic seizures, which have associated serious morbidity and mortality. And then we have auras. Someone sees flashing lights, feels tingling, or absences, which have much less morbidity, much less in the way of serious consequences. And the term seizure applies to both of them, but the phenomenon is quite different. It's very much like Patrick drives his Rolls Royce up, and I drive my 50-year-old Kia, and we both have cars, but Patrick would say what I'm driving is not a car, and I would say what Patrick is driving is not a car. And I don't have a Kia, and he doesn't have a Rolls, but as an example. It's the same term applied, but it has a different meaning and a different implication. So focal aware seizures may not even require treatment. Someone comes in reporting repeated auras. We treat them perhaps only if they're bothersome to the patient, but otherwise not. Or maybe we should treat them because they may turn into something else. It's hard to know what to do. Is there a focal aware seizure that causes limb jerking and falls? Well, that should be treated. So again, someone who sees flashing lights, maybe we leave that alone. Do not be more aggressive. Someone whose arm jerks or leg jerks and then falls or drops things may require more treatment. And clearly, if there's impaired consciousness, we would require treatment, although for some individuals who have very severe impairment, in whom drug therapy might be worse than the seizure. So I have some patients who have profound neurological impairment. They're wheelchair bound. They live in a facility, and their level of function is so low that if the staff of the home notes that they're kind of looking off for 30 seconds every once in a while, I'm more likely to cause trouble with medicine than I am to help that person. So the seizure is overly broad, and the need for treatment may depend upon and may differ depending on behavioral expression. And should we even use the identical term to describe phenomena with variable semiology implications with regard to mortality, morbidity, and need for treatment? I don't know that we should. And now we've seen a lot about interictal spikes, and I'll raise a question: are they really interictal, or do they disrupt behavior, and do they fulfill the definition of a seizure? That is, a paroxysmal excessive neuronal discharge that produces a sign. do they produce observable signs? Well, there was an early report, the first in 1988 by Alan Schumann and Irwin, where they found that posterior temporal occipital spikes impaired reaction time when a digit was presented visually and required a motor response. So they would show a digit and the patient had to hit a button for a motor response. And what they found was that spikes and the slow wave disrupted function. So here we see the spike at time 0, and we see if this is the reaction time, starting a fraction of a second before, reaction time increases. During the spike, it increases even more. During the aftergoing slow wave, it goes up, and then reaction times return back to this 200 millisecond level. So in fact, an interictal spike caused an observable alteration in behavior. A nice paper was published. I think Barbara, sitting next to me, was one of the authors of this paper by Ung and colleagues in Brain in 2017, showing that interictal spikes in temporal neocortex impaired encoding of words. So it's interesting. In temporal neocortex, they were not able to demonstrate it in medial temporal lobe, and there had been several attempts. But clearly, neocortical temporal interictal spikes impair word encoding, an observable behavioral alteration. Our group, one of my postdocs, Liliana Camarillo Rodriguez, who recently moved to Texas, so she's no longer my postdoc, published a paper a few months ago in Epilepsy looking at the effect of interictal spikes on list learning. This was in 78 patients who had intracranial EEG recording in multiple centers around the country as part of a large grant. They were presented a list of words, then asked to do some math for a distractor, and then checked for spontaneous recall. And we looked at the effect of interictal spikes on this. And what had not been shown prior to this paper was that, in fact, during the encoding phase within mesial temporal lobe, you could also impair list learning. So the recall was shown in medial temporal lobe and hippocampus, but not parahippocampal gyrus on the left. In lateral temporal lobe, as shown before, mid-temporal gyrus spikes impaired encoding. And then what also had not been looked at before were subregions, and we found that significant effects were noted primarily in CA1 and the dentate gyrus. There was a trend in the other subregions, perhaps with a larger sample size we might see something, but clearly it was evident for CA1 and dentate gyrus. So there was an observable change in behavior from what we all consider an interictal spike. Moreover, interictal spikes disrupted retrieval in the right hemisphere. So we don't even think about the right temporal lobe being terribly involved in verbal memory, but in fact, interictal spikes in the right hippocampus and parahippocampal gyrus were associated with decreased probability of recall. And there was no effect of spikes in the pre-stimulus period at that point. So here are interictal spikes disrupting memory, an observable behavioral effect. And then work sponsored really and led by Shannon Weiss, who's now at SUNY Downstate in Brooklyn and who was in our center at the time, was also able to show that ripples, so these high frequency oscillations, also impaired learning. So ripples on spikes decreased the odds of successful recall in left temporal neocortex during encoding. So I showed you that spikes in left temporal neocortex, specifically middle temporal gyrus, impair learning during the encoding phase. Ripples on spikes, when you see ripples, that's further impairment. So what do we then make of interictal discharges and seizures? The seizure, again, is a transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. But we've seen a transient occurrence of signs, and I showed you cognitive signs during interictal spikes or ripples, which are abnormal, excessive, or synchronous activity of the brain. Does this mean that interictal spikes are seizures? No. Electrophysiologically, they're quite different. Jean Gottman showed us elegant differences and how they differ in many ways, in response to medication, for one example. But the definition of seizures is lacking, as I said, and it doesn't really fit the evidence. That is, behavioral signs during well-characterized interictal activity. So I made a comment before about cars, and again, if I use the term transportation, I have up here an example of 7 different kinds of transportation, right? We have a car that some of us would like to own and others would be afraid to own for the insurance expense. You know, a moped, John Wayne on a horse, people having fun on a boat, a bicycle, an airplane, a Conestoga wagon. These are all means of transportation. They are conveyances to get us from one place to another. And I would submit that the term seizure is kind of like that. It is a broad term that describes many different phenomena as we currently do it, and our definition, again, has that problem. It lacks specificity, it's overly broad, it describes many phenomena. We use the term like transportation to describe a generic phenomena, and it's really ill-suited to our need, because when I use the term seizure, it doesn't tell me if my patient is still having seizures, do I need to change therapy or not? Do I need to start therapy or not? If that seizure is an alteration in behavior or perception, well, electrophysiologically, some things that we would agree don't fit our present definition of seizure don't comport with that. And again, you know, for example, and I use it for this talk, if I call the company to arrange transport from Philadelphia to Nashville, it's going to matter to me if they showed up with an airplane or a bicycle. How long will I get there? Do I have to work or not to get there? It makes a big difference. They differ in the particulars. So I think what we need really are terms that are far more precise, that discriminate between different ictal phenomena, that bear some relation to the physiology, to the semiology, to the signs that we can detect that are not semiology, and associated risk and morbidity and need for intensity of therapy. So for example, we treat people because they have seizures that we observe, yet I just showed you evidence that interictal spikes impair learning and that ripples on spikes impair learning. But you never try, nor do I, to treat interictal spikes. And why not? Because nobody has ever bothered to develop drugs to treat interictal spikes. But interictal spikes actually have observable behavioral consequence. They impair learning, and your student in school or your employee or you who are working who are having spikes may not function quite as effectively and may have impairments for this, and we don't even think about treating it because we don't think of them as having behavioral consequences in the same way that we think of seizures as having behavioral consequences. So this is, I think, another fundamental problem, that by focusing on seizures as a specific phenomenon, we ignore these other electrophysiological manifestations that are really quite important and can cause cognitive difficulties and impair the performance of our patients and the function of our patients. So we need terms that distinguish, I think, between sustained and non-sustained electrographic events. I think that's one way of thinking about our electrophysiologic differences of seizures. We have sustained and non-sustained activity because both can alter neurologic function. And this is our clinical dilemma, that we're using a term that is so broad to be not terribly meaningful, and it excludes relevant electrophysiologic phenomena that merit treatment. So this is the final statement that we're required to have, the impact on clinical care. I think we have to carefully distinguish between seizure types, not based only on behavior, but implications for therapy and adverse effects. I think we need to think about developing new therapies and new approaches to developing therapy, because interictal phenomena are not benign, and they can interfere with cognitive processes, and we need to change the way we think about epilepsy. And I will end here. Thank you.
Thank you for a wonderful lecture, Dr. Sperling. I would like to call the other speakers to the podium and open the session for questions and answers.
We want to open the session up for questions. There are 2 microphones here and there to ask a question. And there's one there too, it's hard to see. Please go ahead.
I'm not oh my God, it is working. Hi, so I'm Bill Theodore from NIH. This is a question for Jean Gottman. So you made an interesting analogy with SPECT and fMRI. Now, both of them are statistically modifiable and tunable studies. So talking about fMRI in particular, how do you know what the proper threshold is to make sure you're detecting the full extent of the epileptogenic zone at the same time as not allowing factitious areas of increased activity in other regions to appear?
Are you, can you just talk?
Oh, I'm sorry. Can you hear me? Yeah? I'm sorry because I can't see you. There is light there, so I don't know where you are, Bill, but somewhere in there. It's there?
He's over there.
Oh, yes.
Okay. So first, I would not answer with any certainty about any kind. I cannot define any threshold to be sure of anything. But we use, in fMRI, like in many other methods, we use statistics. And what we have studied in particular is not so much the extent of the bold response to epileptic spikes, but rather the location of the peak response. And the reason we have not studied the extent is that it is, as you say, very difficult to find the threshold. We find a peak where it says we are really sure statistically, or as sure as you can be, that this is a significant response. In other words, there is a response there. After that, how far the response goes is an issue of threshold and can change tremendously. And so, in fact, we have not been able to use the fMRI to define the margins of resection or what should be included. What we have demonstrated in the study that I did not mention is that if the peak of the resection, if the peak of the bold response, and in situations in which the bold response is quite isolated, in other words, where we don't have a very widespread, evenly distributed response, if we have a clear peak, if you like, in these situations, if that peak is not part of the resection, the probability was 100% that the patient would not be seizure-free. So we have a very high negative predictive value. The positive predictive value, however, was much lower, and that reflects the problem you're raising, which is that we don't know how to define the margins and the limits of resection with this method. We don't know how extensive the resection needs to be. I think this applies to many of the localization methods that we all use, whether it's a lesion on MRI, whether it's a SPECT activation region. They tell us this looks like it's an abnormal region, but they don't tell us how far the abnormal region goes, what are the margins. And the same, I'm afraid, applies to the bold response to spikes in EEG fMRI studies. I hope that answered your question.
Yeah, thanks.
Question over there.
Yeah, hi. I had a question for you, the moderator, Dr. Sperling. So there's this whole world of clinical neurophysiology that's erupting with continuous EEG. And every day my fellows are diligently marking seizures out in coma patients. And the intensivists are very aggressive about treating these electrographic seizures. And so their definition is very straightforward. If you have a 10-second or longer evolving ictal pattern, that's a seizure. And a seizure is a seizure is a seizure, and they're very aggressive about treating these. And a period shorter than that is a bird. So how should we manage that kind of terminology and this reflex that's kind of erupting in our units with this definition of seizures?
So you raise a good point. I purposely steered clear of that during my talk, hoping that nobody would raise it here.
Sorry. It's a big
because
problem.
it's a big problem and it's a big controversy. And the fundamental issue is that it's not as though Moses had an 11th commandment on the tablet that a seizure is 10 seconds or more in duration. And less than that, it refers to an avian creature entirely, right? So, I mean, there are arbitrary definitions that are useful epidemiologically that make no physiological sense at all. And it makes sense if you want to compare results from one center to another to say it has to be at least 10 seconds, and that way we all are speaking about the same thing, and if it's less than 10 seconds, we're not speaking about the same thing. Now, is treating them worthwhile? That's an entirely different question, and there's really a lack of evidence. I think you and I both know, Greg, there's no evidence that treating these bears any clear relation to outcome. People have not been able to prove that, and for that matter, you know, the 2-second seizure that you and I see that fulfills the electrographic criteria but terminates very quickly, we know electrophysiologically is really the same. So this is a big term, and again, that is even more unsatisfying, and I probably should have included it in my talk.
Okay, we have a question over there.
Jose Cavazos from UT Health San Antonio. Thank you for your presentations. They are very provocative. We talk about two concepts in seizures. We talk about pathophysiologically hyperexcitability, hypersynchrony. And we see, for example, some of the recordings that Patrick demonstrated to us, where some of them have the hyperexcitability, fast local activity. Some of them have more recurrent events. How do you reconcile, from the standpoint of the neuron, as long as that neuron is hyper-excitable, discharging, does it really matter that their neighbors are doing that? Is that neuron having a lack of computational power during that moment, and therefore potentially if we had the ability to ask if that neuron was having a symptom, could we be saying that individual whose neuron, one of that billion neurons is having a seizure? Are we having an issue of levels or systems?
Dr. Chairman.
Patrick.
Oh.
It can be for anybody.
Thank you. It's a very easy question, and I will take 1 hour to reply. No, your question is interesting to me because it reminds me decades ago the discussion about the epileptic neuron. And it was when the time of the penicillin focus and all these pioneering works by David Prince and his pupils. So things are evolved, but relatively recently. In fact, I don't think there is epileptic neurons, or there are aggregates, as we say in the past, of epileptic neurons. That means, as you said, if you consider now at the level of a system, more at the level of the neurons, you can understand more. And I think that the progression from the notion of focus to the notion of network, not only in clinical observation, but also in fundamental, in basic science, has brought a lot of new ideas. I mean, yes, you can have hyperexcitable neurons, but these hyperexcitable neurons can be inhibitory. Mm-hmm. So you see that, and as inhibition is not like in the past one interneuron, but you know that there are 40 different types of inhibitory interneurons in hippocampus and neocortex, you can imagine the complexity of the machinery. But anyway, I think that also the simplification of excitation versus inhibition, that was brought by necessarily by the pharmacologists in the past, but it's far too simple. Now we see that it's not, when I raised the question of inhibition, it was not to say this is inhibition. No, the model shows that it's a tight interactions of complex feed-forward feedback that produce the phenomena. Mm-hmm. And so even if maybe these inhibitory interneurons are involved, they are triggered by the hyperexcitability of the pyramidals. And when you are doing intracerebral recordings, you see very well that it's extremely rare to see a focus in the brain. Even if the medial temporal seizures, it's always, a co-activation of several structures. Even if the frontal lobe, it can be restricted or bigger depending on the pathology, but it's always relatively extended, at least the drug-resistant epilepsy we explore. So I did not answer your question, but I tried to make it more complex.
Sir, thank you.
Okay, the ones in the back.
So somebody in the back.
On your left side?
To the, yeah. Yes.
Hi, my question is for Dr. Spalding, mostly for outpatient management. You talked about electrographic seizures causing symptoms, like for example, memory loss. Sometimes we see tachycardia, bradycardia on ambulatory EEGs. And that raises a question whether we need to be doing screening EEGs 48, 72 hours, which we usually otherwise don't do if patients report clinical seizure freedom more regularly than we do in clinical practice.
You raise an interesting and thoughtful question. How much monitoring do we need to do? I think that it's reasonable to not embark upon large-scale monitoring of the population, just of people with epilepsy, because it would be fantastically expensive and the yield would be very low using modern available techniques. The world is changing, however, and as other methods of monitoring become more available and far more cost effective. I mean, the watch that I'm wearing on my wrist, for example, could be useful, with the appropriate app on it to detect tonic-clonic seizures, for example, as other types of seizures could be detected, and transient tachycardia or bradycardia actually can be detected already. This kind of monitoring might be interesting and useful to do. We'll have perhaps long-term, not so invasive and difficult EEG monitoring methods available either through scalp recording, behind the ear, for example, or even subgaleal recordings now being explored, where we can do very long term. But I think a day or two or three is not going to be terribly useful. And ultimately, it's going to be a cost effectiveness analysis. How much does it cost, and how much benefit do we derive? And can we then develop, algorithms to determine in which people it may be useful to do? But I think this is the way of the world, and probably within 10 years, much longer-term screening will be commonly used in a subset of people with epilepsy.
I'd just like to add something quickly. I completely agree. I think that we really need to go towards these longer-term monitoring. The problem that Mike has emphasized is the so-called electrographic seizure, and I would like to emphasize that there is no such thing as an electrographic seizure. There's only a seizure for which you have not discovered the symptomatology. Because if there is a seizure that you can see in the EEG somewhere, that means there is a large number of neurons that are not working. And so there's something in the brain that's not working. So there is a clinical problem. You may just not have found it, but there is one. And so I think that these long-term monitoring, which of course will not record from the whole brain, but at least hopefully targeted regions, with subgaleal recording or something like this, will really make a very big difference, because the patients are not aware of many of their seizures, and whether you want to treat them is another question. But I think you have to realize that you really don't know very much about your patient's seizures in a way.
Yeah, I agree with you. I think that there are two elements there. First, there is a lot of intracerebral seizures we don't see on the scalp.
Yeah, of course.
If you just take the examples of mesial temporal seizures, you see it after 10, 15 seconds.
Yeah.
Some limited seizures in the orbitofrontal cortex, you never see them on the scalp, etc. So that's the first thing. The second, I totally agree with you about the electrical clinical correlations. And Michael, don't you think that we should make an effort to get more nurses and techs in the epilepsy monitoring unit, more than we did in the past? Because some of the very subtle behavioral correlates you showed beautifully in your talks, if you have nurse or techs more at the bedside, you can discover, I agree with you, much more subtle manifestations which could be electroclinical. But it remains that you have subclinical seizures inside the brain without any correlation we can reach, at least.
Yeah, I guess I should be clear. The point I was trying to make is that, as Jean said, there's probably nothing really that's subclinical. It's at the level of observation and detection. And yes, we can have many more nurses and techs, but it will probably have to have very customized tasks depending upon the cortex where it starts.
Absolutely.
And again, it becomes a matter of expense, or one could simply assume that perhaps all of them have some consequence and maybe should be addressed more carefully.
I just want to add to this discussion one thing. I just want to say, if the patient doesn't notice it, do we care? Is it important when now we see it's happening and the patient has this electrographic seizure?
Well, if the patient is not conscious during that time, then you care. And the patient doesn't know that they're not conscious by definition.
Okay.
But
And if the patient doesn't realize that he or she is not remembering what's happening as well as ordinarily, I mean, so you give a list of 10 words and normally that person would remember 6 and now that person only remembers 3. You may not be aware of it.
The question I have, aren't we creating a problem that may not be a problem?
it may not be a serious problem, but it is a problem in the sense that if somebody is losing their memory or unconscious for some periods of time, it may not affect their life very much and you may decide they don't need treatment. But that doesn't mean there is no problem. And we have not really measured the impact of the problem if the patient is not aware that they're losing consciousness until maybe they have a car accident. And then that's the consequence. So.
Okay.
Even if truly subclinical though, if seizures beget seizures, should we be treating all these subclinical electrographic events if their seizures beget seizures?
Well, that I don't think has been demonstrated. I think that that is much more controversial, I think.
Okay, you are all right-handed. You don't look at your left side.
Yes, we are looking. No.
Okay, thank you very much for the talks. My comment goes to Dr. Sperling. What you said about the effects of interictal spikes on cognition, learning, and behavior is fascinating. And at least in 2 clinical areas, it is coming to clinical research. In children with autism spectrum disorder, we already knew that 30 to 40% of them had interictal spikes. But we used to say, who cares? The child doesn't have a seizure, so I'm not going to treat the spikes. But it is changing. There is some good evidence that if we treat these spikes, we may help the child improve in some domains of cognition. And in the elderly, in Alzheimer's disease, in the past few years, in people with no seizures whatsoever, if they had overnight EEG monitoring and interictal spikes, and in one study showed that if they were prescribed levetiracetam, it could help with some domains of cognition. So I would like to suggest you organize a main session for next year entitled Treating Interictal Spikes in People with No Seizures, and bringing the people with autism spectrum expertise and Alzheimer's expertise to discuss this fascinating area. Thank you.
Thank you.
Thank you.
Back?
So now we go to the back. We don't want to kind of leave anybody out. To the left here.
So, Shandor Benitsky, Denmark. I have a question for Jean. Throughout your presentation, you referred to the spikes as if it was one single entity. But is that the case? And how about the old experimental data about the red spikes and the green spikes? Could that explain some of the heterogeneity of the results you presented?
Thank you, Sandor. Nice to see you. Of course, there are many different kinds of spikes, but I only had 30 minutes, you realize. So, but there are many spikes. And of course, as I tried to emphasize, spikes propagate. And so we record spikes in different regions. And some of them sometimes you record them where they're generated, and sometimes you record them where they're propagated. And they may look a little bit different. They may appear at different times. Unfortunately, they don't look per se so different, so that if you just are given one spike, it's very hard to say whether that spike is at the focus, if you like, or a result of propagation, because they look very often quite similar. There may be some subtle differences. There may be some spikes that are more likely to be at the region of origin. It's been shown with spikes that have ripples on them, spikes that have gamma activity on them, may be more important in terms of localization of the epileptic focus. So there are many different kinds of spikes. I don't dispute that. I'm not sure what probably we can separate the green and the red spikes, as I mentioned, conceptually at least, in terms of the ones that indicate really the region the epileptogenic region, or the region that is likely to generate seizures, and the ones that are from propagation, for instance, with EEG fMRI. I don't know if that answers your question.
How about the spikes that have an inhibitory effect and those that have an proconvulsive effect?
I don't like very much the concept, frankly. I mean, when you talk about inhibitory and excitatory here, you're not talking in terms of cellular mechanisms, but you're talking in more general terms in terms of likely to promote seizures or to prevent seizures. I demonstrated, I think, what are the relationships between spikes and seizures, and it shows quite clearly, I mean, it's been shown quite well. You have shown and others have shown that really the spiking rate or level or the frequency of spikes is a very poor predictor of seizures. And so I don't think, I mean, it's not because you don't have spikes that you're more likely to have a seizure. It's not because you have lots of spikes that you're more likely to have a seizure. I think my view is that really the spikes and the seizures are distinct phenomenon most of the time, and they have some interactions, and we have to see which interactions we observe. And the principal one in focal epilepsy, again, this does not apply to generalized epilepsy, but in focal epilepsy, the one we observe most often is that spikes seem to increase after seizures, which make me think that they're certainly not responsible in any way for causing or for preventing seizures.
Okay, we take a question from back there.
Hi, I'm Eric from Emory. This was a thought-provoking session, so thank you. My question is, as we learn more about the relationship between electrographic and behavioral events and how they relate to space and their relationship with interictal events, how do you see this literature about what a seizure is directly changing or improving our treatment options? Do you think it's about just taking the tools that we already have, like resection and neuromodulation, and making them more precise? Or do you think there's a bigger, more drastic change that's needed in treatment to target this growing literature?
I guess I'll take a stab at that since I raised the issue. I think that we need to fundamentally rethink how we treat epilepsy and how we prevent seizures. I think we need to consider not only preventing them from starting, but as I say, altering the interictal activity. And Ali raised an interesting point in autism and Alzheimer's about treating spikes, but you're not really treating spikes. You're giving drugs that treat seizures, although they have some effect on spikes. It's rather modest, probably, in changing the behavior. I think, so in answer to your question, I think we really need to reassess what we do, how we do it, and entirely new avenues. And I think some of the drugs that we currently employ, or surgical techniques that we employ, tackle the problem to a certain extent, but it's by dumb luck more than anything else. We have certain models that were developed in animals that mimic aspects of human epilepsy, and then the drugs or surgical techniques that were useful in these models can be useful in humans as well. In surgery in particular, I mean, epilepsy surgery started before EEG was even developed to treat people. And the first operation for epilepsy was done in 1886, long before Hans Berger ever was involved in doing EEG in humans. And it was going after lesions. And it goes really to the multifactorial nature of epilepsy and the concept really that the pathophysiology differs tremendously between different types of seizures and different types of epilepsy. So I think it really requires a fundamental thinking of it. And I think we are stuck in a scientific rut to a certain extent.
I'd like to add something. I think that I completely agree, and I couldn't support more the idea that the spikes or HFOs, anything that is really behaving abnormally, results in an impairment. It's almost trivial to say that. If a large number of neurons are not doing what they're supposed to do, then of course there must be an impairment. So an aspect of the work that has been done recently that you presented and Barbara has done on the effect of spikes on memory, for instance, or word encoding, what I find is missing at this point, we know that most of these patients also have lesions in these regions. And there's pathological tissue, there's cell loss, what is the share of the cell loss in the memory, for instance, in the memory problem? because obviously if there's cell loss, there is not normally functioning brain, and there's probably memory problem if it's in the hippocampus. And there's spikes as well, and the spikes contribute to the memory loss. Do the spikes contribute 10% of the memory loss, 90% of the memory loss? I think this is a very fascinating area for the young people who are looking for research there. It's something to try to sort out. I think would be very interesting.
We're gonna go over there, yeah.
Thank you so much for the lecture. My question is for Dr. Chevelle. And I just was thinking during your entire lecture about how I use closed loop stimulation, such as responsive neurostimulation, and I wondered if there's like an ideal time like that you think would be best for aborting seizures, such as should we maybe look at the pre-ictal sort of build up or during the ictal phase?
I have no idea. To me, the RNS and are still a mystery. I mean, their mechanism. I agree that there are some series demonstrating their relative effectiveness, but I am not sure about their mechanism. So, and also the question is, you know that sometimes the stimulation is effective when you stimulate in the so-called epileptogenic zone, but sometimes it's as much effective if you stimulate elsewhere. So really, I am not an expert of deep brain stimulation or RNS, but I think we miss a lot of, I would say, clinical research about the real mechanisms of the stimulation. Also, it can change drastically from one part of the cortex to the other. And the mechanisms also now of deep brain stimulations in the basal ganglia is totally another world for all the mechanisms we talked about. So I don't know.
Thank you.
We go to Rod.
Rod Scott from Nemours Children's Health in Delaware. So I have some deep discomfort about a lot of the stuff that's being discussed here. As probably is my want. It's the way I tend to do things. I think there is a lot of literature from the epileptic encephalopathy world that really argues against the idea that the seizure or the intractable spike or any of those things are contributing a huge amount to to the observed cognitive impairment anyway. And fixing those things with surgery or whatever approaches we take very seldom, if ever, recovers my patient's IQ beyond a few IQ points. I never have turned a patient with autism to one that doesn't have autism by treating the intractable spikes. So at some level, I think we have to talk about the thing that's causing this spike. And the thing that's been missing from this entire conversation is etiology. And I would argue that fundamentally the thing that's causing the seizure is the thing that's actually problematic. The seizure itself is simply an expression of the network. What we really need to understand is what's underpinning all of that and try and fix that. And I would imagine that's got a much better chance of improving cognition.
Well, who wants to answer that question?
I would answer yes. I fully agree with you. I mean, you know, we are observing things. And for instance, the observation that spikes impair cognition is a measurement. And they do. The spikes, in other words, cognition is impaired at the time of the spike and not at other times. This is what the measures show, whereas the tissue is the same during these two periods. So now, as I was saying earlier, what is the importance of this impairment compared to the impairment that is brought up by the underlying lesion or pathology is another question that we have not answered. And maybe most of it is, we don't know. If we could find a mechanism, find whatever is causing all of these events, spikes and seizures and everything else, and prevent that from occurring, it's obviously the best solution. I mean, to me, it's very clear. I don't dispute that. And I agree that there could be more work done on different types of lesions, for instance. Maybe the same spikes occurring in different pathological background could have different effects. And maybe they have minimal effects in some situations, in others. I think this whole field is just starting. Yeah. And this would be very exciting.
Yeah. So we will allow 2 more questions. Yeah.
If I may just respond to Rod also. And I agree with you, Rod, but I think we also have to consider who we're dealing with. So your patient with the epileptic encephalopathy is in perhaps a very different situation than someone who functions at a different level. And tinkering at the margins to a certain extent, as you're saying, may make a difference for some people and not others. This is part of what we need to learn. Another consideration, too, is that the spike and its propagation have been shown to alter brain connectivity in some ways, and that perhaps by dealing with the spikes, we can restore more normal patterns of neuronal interactions and more normal networks, which would then facilitate better behavior and less adverse behavioral consequences. So that's one of the things, that's one of the areas actually where we're starting to do some investigations now, that if the spikes and the seizures are hijacking networks and causing activity to flow in directions that are not useful, by suppressing some of this activity and then perhaps introducing other mechanisms through stimulation or other means, can we restore more use of more normal pathways and perhaps achieve a better result? So that's something else to consider.
Or vice versa.
Or vice versa, yes.
Thanks for all the speakers for the wonderful lectures. The question is for Dr. Gottman. Have there been any studies about the pathophysiologic cellular mechanisms that underlie the interictal spikes versus the ictal spiking?
I don't know. I'm not very sure what you mean by the ictal spiking, in the sense that during seizures you have this, what from observation we define as a different phenomenon, because it's a rhythmic continuous activity. And so on one hand, you have the interictal activity, which by definition is an isolated wave, an isolated event. And the other case is a rhythmic continuous event. And of course, there has been a lot of work done on different mechanisms using different models. I think that what Patrick Chauvel indicated at the end there, the hypothesis that has been reported from Avali's group in particular and others, that this initial inhibition at the onset of seizure, excessive inhibition, in other words, creates the rhythmicity, creates the rebound excitation and etc., which results in this rhythmicity, and maybe the continuing event is a very interesting one. But yes, I don't know. We can talk about this for a long time.
Last question.
Thanks. Last question. It's a curious question. And I'm Gabe Marks, by the way. Thank you, guys. We focused a lot on what's causing seizures and how to stop that. And we know that some people, for example, with FCD might be spiking almost all the time, but they don't seize all the time. So I'm always curious, if you picture someone throwing matches on the forest floor, and we have devices and meds that might throw water on that match, but sometimes the forest floor is really dry and sometimes it's not. And I'm not really aware of how to look at the forest floor very well. There's maybe some coming out with ultradian rhythms and circadian rhythms. Are you guys aware of, are you people aware of any new windows into the state that the brain's in to allow a seizure, and how we might augment that? I don't know if VNS or DBS are doing that, for example.
I don't know. I mean, I really, there's been a lot of work that show us that there are, as you say, cyclical periods. And, with respect to sleep, I mentioned it, there's some times where you're more likely to have a seizure. These are all kind of, there's a menstrual cycle in some patients. There's some general facilitating or inhibiting periods, but I think they tell us very little about, as you say, why a seizure occurs now as opposed to even in 5 minutes from now when all these conditions are the same. I have absolutely no clue.
Okay, one last.
Barbara, thank you for this one last question. Gary Kalamangalam from the University of Florida. Thank you very much to all the speakers for a fascinating set of talks. Mike Sperling, I do have a patient almost exactly like yours. What I did for him, the person with the RNS that you mentioned, I increased his medicines, but I allowed him to drive. So we both remained happy. That was a way out of dealing with electrographic seizures that the patient did not report. But the suggestion is just this. There's so many interesting things that have been pointed out. But, one could even argue that to precisely get to know what is happening in a patient's brain is perhaps impossible. You might operate on a patient you may have sampled with SEEG, etc., but then you take it all out and then you operate on the patient. You have no idea 2 years later whether they're spiking from the opposite hippocampus or not, but they're just not telling you because they don't have symptoms. And you're not going to go and put in an SEEG just to find out. So some of these issues might actually be unresolvable. So what about just taking a purely clinical, phenomenological approach? Are you, the clinician asks the patient or the physician evaluates the patient for impairment. And maybe the way forwards, just a suggestion, would be to develop good, robust clinical methods to detect impairment. And it might be that someone has a spike that's impairing them, but you don't care, because if they're impaired, you treat them. Someone might be seizing, but not impaired, and so you don't worry about treating them. So maybe we regress to our clinical roots and develop sophisticated, advanced methods of detecting impairment, perhaps over several hours or even a day or whatever, if you have to in certain patients, and you make decisions based on what you find at that level.
It's electroclinical correlations. That's it.
Yeah, but here you would get rid of even the electro, in the sense that you would never be able to establish completely, right?
No.
So you just go by what is considered to be significant impairment, like examining someone with Parkinson's. Can they walk? Can they get around their daily business? Or someone with spasticity, are they functional? Are they not? And you develop a system by which you assess this in some comprehensive way, and treatment decisions based on that.
And the issue in epilepsy differs from Parkinson's or spasticity. Spasticity is present when you see the patient at that moment. Parkinson's patient, you may have to monitor over the course of a day or several hours. In epilepsy, you may need to really assess that person over weeks or months to understand the impairment. So I agree with you, you're right, that's ultimately the most important thing, but the baseline assessment period might need to be very long, and you may need fairly sophisticated tools, and we would have to avoid being burdensome as well.
Okay, with those words, we want to thank our excellent panel and speakers for an excellent symposium. And the Fundamentals Symposium will start at 12:30, so make sure you get some lunch.